Dear KGMOA Kottayam District President Dr. Preetha S.Y., Distinguished Speaker of the Day, Professor Sanjeev Nair, dear faculty members of Academic Cell, Dr. Praveen K.S., Balendra Sir, and Tony Thomas, and my dear KGM members. It's with great honor and enthusiasm that I introduce to you Dr. Sanjeev Nair, Professor, Government Medical College Hospital, Trissur, a distinguished expert in the field of medicine, particularly renowned for his expertise in tuberculosis and its treatment. With an illustrious career spanning decades, Dr. Sanjeev Nair has dedicated his life combating one of the world's oldest and deadliest diseases. As we gathered here today, we have the privilege of delving into the depths of tuberculosis, guided by Dr. Nair's profound knowledge and unparalleled insight. His contributions to the field have not only advanced our understanding of the disease, but have also saved countless lives. Dr. Sanjeev Nair's passion for eradicating tuberculosis is evident in his tireless pursuit of innovative solutions and his unwavering commitment to patient care. He is currently the chairman of Zonal Task Force of Medical Colleges, National Tuberculosis Eradication Program, and also chairman of State Working Group for Latent TB Infection, and he is a subject expert for NTEP program. Moreover, he is the president-elect of the Academy of Pulmonary and Critical Care Medicine. I also thank Dr. Preetha S.Y., President of KGMOA Kottayam, for arranging this talk by Dr. Sanjeev Nair in cooperation with the Academic Cell 2024. I also welcome all the members of KGMOA on behalf of the Academic Cell. I especially appreciate Dr. Tony Thomas, the convener of the Academic Cell, and distinguished faculties Dr. Balachandar and Dr. Praveen K.S. for their unwavering support and dedication. We are happy to announce a statewide sessions to help KGM members to get familiar with the topics who are preparing for NEET PG in April itself. This is an innovative move from the Academic Cell of KGMA 2024. Dear friends, as we listen to Dr. Sanjeev Nair's words of wisdom and expertise, let us be inspired by his dedication and let us join hands in the fight against tuberculosis. Without further ado, please join me in welcoming the esteemed Dr. Sanjeev Nair to this Zoom platform. Sir, welcome to the Zoom platform. Thank you all. And with this, I hand over the mic to Dr. Preetha S.Y. for to have few words, especially on this World TB Day. Over to you, Dr. Preetha.
Thank you, Dr. Vincent. എല്ലാവർക്കും നമസ്കാരം. സഞ്ജയ് സാറിനെ കുറിച്ച് ഡോക്ടർ വിൻസെന്റ് ഇപ്പോൾ പറഞ്ഞു. എനിക്ക് ഒരു കാര്യം കൂടി ആഡ് ചെയ്യണമെന്ന് തോന്നുന്നു. ഹീസ് ദ ഫൈനൽ വേർഡ് ഇൻ ട്യൂബർകുലോസിസ് ഇൻ കേരള ആൻഡ് ഇൻ ഇന്ത്യ. ഈ വേൾഡ് ടി ബി ഡേയിൽ നമുക്ക് വി ആർ റിയലി ഓണർ ടു ഹാവ് യു ഹിയർ സർ. എനിക്ക് ഈ ടി ബി ഡേയിൽ ഒരു സെഷൻ കണ്ടക്ട് ചെയ്യുന്നതിനെ കുറിച്ച് ആലോചിച്ചപ്പോൾ പാലയിലെ ചെസ്റ്റ് ഫിസിഷ്യൻ ഡോക്ടർ ഷിനോബിയാണ് സാറിന്റെ നമ്പർ തന്നത്. സാർ ഭയങ്കര ബിസിയാണ്, ടൈം കാണുമോ എന്ന് അറിയില്ല, മാഡം ഒന്ന് വിളിച്ചു നോക്കൂ എന്ന് പറഞ്ഞു. ഞാൻ വിളിച്ചപ്പോൾ തന്നെ സാറിനെ കിട്ടി. സാറ് ഓൺലൈൻ ആണോ ഓഫ്ലൈൻ ആണോ എന്ന് മാത്രമേ ചോദിച്ചുള്ളൂ. അപ്പൊ തന്നെ സമ്മതിക്കുകയും ചെയ്തു. ഇത്രയും ബിസി ഷെഡ്യൂളിന്റെ ഇടയിൽ നമുക്ക് വേണ്ടി ടൈം കണ്ടെത്തിയതിന് കോട്ടയം KGMOA is really thankful to you, sir. കോട്ടയം KGMOA ഓരോ മെമ്പേഴ്സിന്റെയും സ്റ്റേറ്റ് അക്കാഡമിക് സെല്ലിന്റെയും ഹോൾ ഓഫ് ദി KGMOA ഫ്രട്ടേണിറ്റിയുടെയും കണക്കായിട്ട് നന്ദി ഞാൻ ഇവിടെ രേഖപ്പെടുത്തുന്നു. അധികം സമയം കളയുന്നില്ല. ഇന്നത്തെ ഈ സെഷൻ എല്ലാവിധ ആശംസകളും നേർന്നുകൊണ്ട് നമുക്ക് ഈ സെഷൻ ആരംഭിക്കാം. ഓവർ ടു യു സർ.
Thank you, Dr. Preetha. Just share my slides. So thank you, Dr. Preetha, Dr. Vincent, for the kind introduction. Am I audible?
Yes, sir. You are audible.
Yeah. So, I mean, Dr. Preetha called me and I immediately said yes, because I have a history with KGMOA. I was a Trissur KGMOA secretary for 2 years. That too at a time when there was a north-south divide, and it was North versus South, there was a huge conflict going on, and the Trivandrum like me was made the secretary of Trissur branch. And I was sitting all the time and listening to my seniors sitting there and saying, Trivandrum ശരിയല്ല. Then I'll remind them gently that I am a Trivandrum. And they would say, so that was, and I remember that because 3 days back we had a API meeting here with all Trissur senior physicians coming, and Dr. Rajan Warrier and others. Dr. Rajan Warrier was the previous ex-president of KGMOA. So he was remembering those days. So I was also reminded of those days. Anyway, happy to be back with the KGMOA family. I still consider myself one of among you. Of course, I have some of my classmates in this group and some of the seniors also here. I welcome all of them. I think my issue is that somebody has to keep reminding me of time. I might lose track of time. Dr. Vincent, I would be happy if you tell me when half an hour is over, because I get carried away. Now, and I'm also open to interruption. If there is some point somewhere which somebody needs to clarify, you can put up a question. Dr. Vincent can raise that question in the midst of it itself, so that we don't have to wait till the end and lose track of what the person wants to ask. I'm open to that as well. No issues in any interruption. So basically, it's a vast topic. I was discussing with Dr. Preetha and Dr. Vincent and what exactly we need to discuss, which was a bit difficult because, we all kind of agreed that everything needed to be covered, which means that, very little time is there for covering each aspect of that. In any case, I tried to put up certain things. So I'm hoping that, this time that we have, I would be discussing a bit on the epidemiology of TB, which is necessary because all of us working for the government, we are all duty bound to work for the TB control program, the TB elimination program. So we need to know in what context we are working. Move on a bit to the diagnosis of pulmonary and extrapulmonary TB. Why extrapulmonary, I'll explain later. Diagnosis of TB infection, which is coming up in a big way because these days we are managing TB infection in addition to TB disease. There was a time 10 years back when we would say that in India, we would not be managing TB infection, but we have come a long way when to manage TB infection as well. And finally, the treatment of TB disease, as well as a couple of slides on the treatment of TB infection. There's a slide that all of us working in the program use constantly. This is from the current global TB report. The global TB report comes out somewhere around October every year. So this report is the latest one. And as was there in the last year, talking of more than 1 crore TB cases everywhere in the world occurring every year, out of which more than 1/4 are in India, with about 28 lakh cases every year. It's a huge burden that we are taking. And of course, more worrying than that is the death. That is, you have about 3.5 lakh deaths every year in India, which is again more than 1/4 of the global deaths that occur due to TB. And in terms of multi-drug resistant TB, at the bottom of the list, you can see for that also, India actually has more than 1/4 of the burden. The only place where we actually, are maybe behind the world, which is good for us, is in HIV TB, where, our numbers are low. So that way we are, better off than rest. If we add that also, that would have been a huge problem for us. Until recently, we were talking based on always talking based on these WHO estimates. You have to understand they are estimates. These are not calculated figures based on any studies or anything. There are various methods, epidemiological methods of estimating this. So it's not always foolproof. But then in the recent past, finally, our country did a TB prevalence study, which was needed for a long time. We've been talking about it for a long, long time. But finally, the country managed to do this, and the report is available. I would really recommend that whoever feels like reading this, go to the TBC India website, tbcindia.gov.in website, and you can download this, summary report. It's not very long, and just look at where Kerala stands in many of those aspects. Now, the main findings of this particular, prevalence study was that there are about 312 cases per every lakh of population in India. That is microbiologically confirmed adult cases. This is only the adult study only covered the adult population. And of course, they had state-wise estimates also. So in terms of microbiologically confirmed adult pulmonary TB, Kerala is doing best. So we have only about 115 per lakh of microbiologically confirmed pulmonary TB. Whereas at the top, you can see states like Delhi and all, which have 5 times the number that we have in, almost 5 times the number we have in Kerala, more than 500. UP, Rajasthan have almost 500 per lakh. So there's a huge difference in the country in terms of the occurrence of the prevalence of TB. The other thing, for long we were saying that the proportion of infection in India, prevalence of infection, TB infection in India is 40%. The current study says it's somewhere around 32%. So that is also coming down. With respect to Kerala, we saw the estimates in terms of the microbiologically confirmed, pulmonary TB as 115 per lakh. But in terms of, estimates for infection, which is not really there for state-wise in that study. But in the recent past, Dr. Aparna and all of us together, we did this particular study in Trivandrum district, which looked at the prevalence of infection in Trivandrum district. And the district-wise estimate was somewhere around 20%. So 1/5 of the Kerala adult population is infected. So even though the proportion of TB in terms of microbiologically confirmed pulmonary TB is low, 115 per lakh is almost, it's just like 0.1115%. So it's less than 1% even. But when it comes to infection, the 20% of the adult population is infected. So we should remember that there's a huge chunk there. So when this particular study was published, we had a lot of hue and cry because newspapers picked this up. And then one of the senior policymaker doctors kind of quarrel with us saying that, your study must be wrong. But then we had another study which we did to validate, it's not a really study for prevalence estimation. There's a study that ICMR study in which we gave the biggest sample, where we are trying to validate a new antigen which is now going to be used for testing for infection called the CTB, which is now called the CYTB. So for that, we had samples from 3 districts in Kerala, and the district TB centers had taken the lead to do that. So in all these 3 districts also, Kollam, Trissur and Kannur also, we got about 20% prevalence of infection, which means that in Kerala, generally around 20% of the population is infected. You remember, there's a difference between infection and disease. Infection is, I am definitely infected. Most of you would also be infected. Infection means that the bacteria have entered our body. There is an immune response to the bacteria. But then we don't have any signs, symptoms, or investigations will not show anything suggestive of TB in our body. But the moment we develop symptoms, some lesion appears on X-ray or a lymph node appears or something happens, you call it disease. So that is the difference between infection and disease. Infection is quite common in India and also in Kerala. Disease is not that common. The other important thing which came out of the prevalence study, which has relevance for us, there's one more thing which I didn't put into the slide, but this is something that always, I hear when I go outside Kerala and meet the national experts. So they brought out a new indicator called the prevalence to notification ratio, which for India, for example, the ratio is 2.84, which means that for every 284 cases that are prevalent in India, only 100 are notified. In that particular indicator, Kerala is behind the rest of the country because as per this particular study report, for every 333 prevalent cases in India, in Kerala, only 100 are getting notified, which means that we might be missing a large number of cases. Kerala case it's a very sensitive issue. We can't understand how we would miss cases in Kerala, but then that is what the study says, and that is what national level epidemiologists always talk to me. So that is one thing about missing cases. And the second thing is generally in our system, if suppose I tell somebody that, there is a tribal death in a particular tribal colony, the immediate response of our health system is that we go there, we do a, door-to-door survey in which we look at symptoms, and people who have symptoms, we will test for disease. But this particular prevalence study says that almost half the patients who was diagnosed to have TB in the prevalence study did not have symptoms. Which means that if you're going to do door-to-door screening and you're basing on your screening on symptoms alone, you will miss about half the cases. Until recently, we used to believe that if we looked at the symptoms carefully, you could pick up 88% of cases. So you will miss only almost 10% only. But now we know that we might be missing even more cases. And the study showed that those cases can be picked up only if you take an X-ray. Now, for long, the beginning when I started my career long back, I started my career as a district TB officer of Idukki in 2001. So in 2001, 2 years, I was the DTO of Idukki when I was in the health service department. So those days and all, program managers often looked down on chest X-ray. I remember a very famous story where in the state level training center at STDC in Trivandrum, one of the senior most pulmonologists who was working in the health service department was invited as a trainer to the state level training where doctors from all over the state had come. So he came with a bag full of X-rays, and The then WHO consultant threw him out. Very proudly he was saying that I threw him out because he came with X-rays. Who would bring X-rays to RNTCP training? Now the point is, people thought that you should not look at X-rays at all, but now everybody knows that you cannot manage TB without X-rays. So the world has come a long way from the previous beliefs. We are now in what is called the End TB strategy, and this has started from 2016. So from 16 onwards, we are on the End TB strategy. It's a very ambitious strategy. So the strategy actually looks at reducing mortality by 95% by 2035, reducing incidence by 90% by 2035, and there should be no catastrophic expenditure for TB patients starting from now. It's not a future thing. Even now, nobody should have a catastrophic expenditure. Now, the SDG targets on which the government of Kerala was working are the 2030 targets. So all the other diseases we're looking at SDG targets. And the Health Minister of India, Dr. Harshvardhan, went to the World Lung Conference and he declared that India will achieve the 2030 targets by 2025. So that is why the whole country is now in a rush to eliminate TB by 2025. It's a faraway dream, and we should understand that all of us technically, when we speak about TB, all of you are speakers, you go around speaking about TB, should be very careful on the words you use. So what we are trying to do is end TB. This is what is that we are trying to meet the targets of the NTB strategy. Whether we will meet the 2030 targets by 2025 or all is a different review. The NTB says there are targets for 2030 and 35. So that is what we are trying to do. The program has been renamed, I'll be coming to that, as a TB elimination program. But TB elimination means that there should be only one case per million population. Currently in Kerala, we have more than 600 cases per million population. So going down from 600 per million, what we have currently, to 1 per million is a long dream. I mean, we should always be trying for that. There is no harm in dreaming and going for strong, difficult targets. But we should remember that, it's not going to happen very soon. The other thing is, for reaching these targets, what we are currently doing. So if we continue doing what we are currently doing, if you look at the dotted red line, you will only reduce incidence by around 20-25%, which is not enough. You're trying to reduce it by 90%. Now, if you optimize all your current tools, have universal health coverage, do everything perfectly, still you will only reduce it by around 75%. Still you will not reach the target. To reach the target, you need newer vaccines, newer ways of managing latent TB infection, and so many other things which have to come up, and it was expected that these things will start coming up by 2025. So even current tools optimally used will not help us reach targets. You need even new tools. The program looked at all these targets and all that and got named as a National TB Elimination Program. We should remember that it is still elimination program and looking at for elimination. Eradication of TB is not possible, and nobody speaks of eradication of TB. So be very careful when we use the terminology, because you are all called to panchayat meetings, at state level meetings, district level meetings. Always be very careful in the terminology used. Now, with all those targets, how well we are doing? We are reaching 2025. We are almost there. And WHO looks at it every year. And in terms of global figures, you can see that by 2025, it was expected that incidence will reduce by 50%. It reduced less than 10%. Expected that deaths will reduce by 75%. It's reduced only less than 20%. Catastrophic cost should be 0, but still it is at about half. The patients still have catastrophic cost. So we are very far from meeting even the 2025 targets. So, there's a lot of work to be done. And our slogan for last year and this year is, yes, we can end TB. So then the question we have to ask ourselves is, can we end TB? So forget about elimination and eradication for some time. Can we actually end TB? Now, it's a difficult question. You have to search your heart for answers. And I would say, yes, it's a question of but when. That I am not going to talk on when. But you should remember that to end TB, old strategies, we are not of new strategies being done, but even in the scenario of all the new strategies that we are trying out, remember that there are two important strategies which remain from the past, which remain even now, is that you have to diagnose TB cases as early as possible, to prevent spread and cure them early, and also treat the TB adequately, ensure that patients take full treatment and all, to prevent spread of disease and to save lives. So, this is the basis of any kind of TB program, and that is still applying to all of us. In that context, last 1 week, we were getting repeated TB cases getting admitted and diagnosed in our hospital. So I just took 3 of them to share with all of you. You can look at case 1, cough of 3 months, lady, elderly lady, cough of 3 months. At cough of 2 weeks, this patient should have undergone a sputum examination. But you can see that this lady went to multiple hospitals, local hospitals. She was from Trissur, KGMOA, went to multiple hospitals. Nobody did a sputum, nobody did an X-ray. And then she went to Ayurvedic treatment, which she took for 3 months. And finally, when her disease worsened and she was very sick, she reached radiologist, where in addition to an X-ray, a CT scan was done, sputum was done, and came as SNAT showed MTB detected, TB was diagnosed. Remember, there are people at home and there were 2 children in the house less than 5 years old. So the amount of spread that occurs, you can imagine. The second patient is even worse, because patient from Palakkad, Vadakancheri, this patient had a cough of 6 months duration. Now, you have 2 weeks, you're supposed to do sputum examination, but at 6 months also, nobody has done a sputum. He was having cough with expectoration on and off for such a long time. But still, he did not come to a bigger hospital where an X-ray could be done. And finally, he reached when he developed hemoptysis. That time he had fever on and off all this while. But, look at the way the patient was evaluated. Finally, when he reached radiology, the NAT was done and TB was diagnosed. Now, we live in an era when, we all complain that there are only nuclear families, the old joint families are gone. But in this case, suddenly you have a joint family with about 11 members staying in the house. And there are 4 close relatives who come very frequently and stay overnight and go around. So, elderly people, other elderly people in the house, children in the house, multiple children in the house, all of them would be infected. So again, that shows the other. Now, the third issue, which I always, puts me in a lot of dilemma, because I balance between the private sector, the government sector, and the governments inside the government sector, between the meteorologists and the health service department. And our major crisis, interdepartmental crisis occurs when we get cases like this, which is becoming more and more common. Totally homeless patient. He belongs to Trivandrum, but, he is traveling all around Kerala. The last place where he is residing for some time now is Trissur. In between, he had just recently, last week, he had been to Nilambur and he came back. He has no bystanders, no place to stay, no house. And he has come with such extensive disease. Sputum done, of course, NAT was positive. Now, because he has no relatives and no home, I have admitted him. Now, you should remember, one of the crises Kerala is facing today is that throughout Kerala, there are no beds for TB patients. I was working in the health service department when I was working in Chalakudy Taluk Hospital as MOTC Chalakudy, TU. At that time, I had a 14-bedded TB ward in Chalakudy Hospital. Multiple hospitals like Kottayam Hospital. Many of the hospitals in Kerala actually had TB wards. District TB centers all over Kerala had TB wards. Now, all those wards are closed down. Many of the medical colleges do not have TB ward. And as a crisis occurs when, somebody from the health service refers a patient to meteorology, and the meteorology doctor says, this patient does not really need IP care. Why can't you manage in your hospital? So the health service doctor will say, no, I have no beds. The meteorology doctor will say, I also don't have any beds. So, there will quarrel and people you often die also. So this is a crisis we have, and such people are spreading TB in the community. If you come to my ward in Trissur, you will see at least 4 or 5 patients admitted at sometimes who all stay at Guruvayur around the temple. They don't have houses. They stay on the street around Guruvayur. And you can imagine the crowds in Guruvayur if you've seen them. These same people will be begging around and, spreading TB among those people. They don't take medicine regularly. So this is a crisis that we need to address, and we don't have any solutions also. So how do we diagnose all these cases? Is it so difficult? Is that why these patients are not diagnosed? There is no difficulty at all. All these patients can be diagnosed very easily. You all know the diagnostic algorithm. So here what do you have? Anybody who is a presumptive pulmonary TB. And a presumptive pulmonary TB definition is so simple that even a doctor is not needed there. Anybody with cough more than 2 weeks, anybody with fever more than 2 weeks, significant weight loss, or a hemoptysis, or any lesion on an X-ray, immediately suspect TB. All that you need to do is start with the X-ray and sputum examination. If the sputum is positive, obviously you're diagnosing TB then and there. If the sputum is negative, but if the X-ray is suggestive of TB, today we have these nucleic acid amplification tests. If the sputum is negative and the X-ray is normal, then obviously you'll evaluate for other causes, but still TB may be possible. Now, even the sputum positive patients, today you want to know rifampicin resistance. So you, as part of universal DST, again, you will do a NAT. And in many of the districts of Kerala, today you have something called upfront NAT, so that the sputum and X-ray need not be done. You can directly go to the NAT also whenever you have a patient like this. So the point here is that finally all patients will end up in a nucleic acid amplification test. So then people would ask the next question, is it so difficult to get a nucleic acid amplification test done? In some states, even one of the neighboring states where I attended a meeting 2 days back, they were saying that they are not having too much of access to network. It comes to these new tests, many of them are available and the program provides almost all of them. So the most important one today are the NATs, the gene expert, or what we call the cartridge-based nucleic acid amplification test, or CBNAT, which allows for diagnosis of TB and rifampicin resistance. And the other main one is TrueNAT, which is a chip-based test, which is a real-time PCR chip-based test, which again is a point-of-care test, which can be kept battery operated, can be kept to the periphery. The government policy is that this goes at district levels and higher, the gene expert, and the TrueNAT can be taken down to the taluk hospital level, and that is how it is being kept. Then you have this test called the line probe assay, which is kept at 2 labs in Trivandrum, one at the IRL at Trivandrum, and the second one at Calicut Medical College. So those are 2 places which have line probe assay. You have solid culture, which is slowly being phased out. But now again, we are doing a bit of solid culture, again being done for us in Trivandrum and Calicut. And liquid culture, which is done with a machine called Mycobacterial Growth Indicator Tube, or the MGIT machine, again available for us in Trivandrum and Calicut. So these are the tests, and all of them are actually available for us. Now, is there any difficulty in accessing these tests? The Gene Expert and the TrueNAT. The Gene Expert, I don't know how many of you have seen the Gene Expert machine. It's a very small machine. You compare the cartridge to my hand. It's a small cartridge. You just have to mix the sputum with the 1 ml of sputum with 1 ml of solution and load it into the cartridge and just push it inside, close this lid, and within 2 hours, machine will tell you whether Mycobacterium tuberculosis is detected or not, and whether if it is detected, whether rifampicin resistance is detected or not. So it's very, nothing much to do. I mean, no technical steps at all. The other machine is TrueNAT, which it's an indigenous machine. So it's developed by Mod Biotechnologies in Goa, and it is our own Indian machine. So, there is greater access to this machine. It has been validated by ICMR. It is bound to be equally as good as the Gene Expert machine. Only issue is that it needs more technical steps. You can see that, multiple steps are there. There are it's a 2-step machine. And even though it works very well in good labs, often when it is taken to the taluk hospital level and all, if your lab technician is not very, good with the various steps, the machine can give you wrong results. So often this machine is criticized because of wrong results coming in. Should remember that is not a problem with the machine. It's a problem with the way we use the machine. And the machine is available all over India. You can see the Indian map. It's a dense map with machines all over India. This is a bit of an old, outdated slide. At this point, we had only 4,700, but the aim of the government is to have at least 8,000 such machines all over India. And the other thing which is coming up in a big way are these X-ray vans, which also increase the access to X-ray. In fact, when the new algorithm, which I showed you earlier, came, our major crisis in Kerala was not doing the sputum or the NAT. Our crisis was how to take an X-ray. Many centers did not have, many PSCs, of course, have no access to X-ray. The then Health Secretary Rajiv Saran sir suggested that let people take X-rays in the private sector. We'll reimburse it from the government. But then we found that in such places, like near PSCs, often X-rays are not available there. For taking an X-ray, the patient will have to go to the taluk headquarter level, and there the government has an X-ray, so there is no point in outsourcing. So it's a bit complicated, but these vans are available in many states in India. Kerala is a bit behind in that. We don't have too many vans like this. Now, just again, telling you what these nucleic acid amplification tests do. So in sputum positive specimens, which could be diagnosed without these tests even, the sensitivity and specificity are very high. But then, like I said, these patients who have sputum positive, culture positive, they can be diagnosed even without a NAT. So that utility of the test in that scenario is not that optimal. You need it when the sputum is negative and the culture is positive, which we earlier used to call as smear negative pulmonary TB or the X-ray positive pulmonary TB. Those cases, mistakes can occur in interpreting X-rays. So there, this test is very useful because half of such cases can be diagnosed with a nucleic acid amplification test. But you should remember it's still only half. Specificity is very high. So even today, out of all your pulmonary TB, only around 75-80% can be diagnosed by a nucleic acid amplification test. The remaining 20-25% still need diagnosis with the X-ray. So don't forget that because the good tests, the best tests are available with us, doesn't mean that we can diagnose all cases with them. We still need X-rays for diagnosis. And these tests also give you a result on rifampicin sensitive, resistance, for which the sensitivity is also high, specificity is also high. So generally it works very well for us for rifampicin resistance. Now, in addition to rifampicin, we need to know resistance to other drugs like INH, fluoroquinolone, second line injectable, ethionomide, and all that, which the line probe assays will give you. These are tests which are more complicated than what the other tests we discussed. These are, like I said, available at Kozhikode and Trivandrum. The advantage is that multiple drugs resistance can be known from this. The disadvantage is you need bigger infrastructure, you need accreditation, lab technicians, training, and performance. And it works only in smear positive patients. So if the sample is smear negative, they will have to culture, and the culture isolate goes into a line probe assay. So if it is a smear positive specimen, theoretically you can get result in 3 days. But if the nucleic acid amplification test give you a result in 2 hours. Now this can give you a result in 3 days if it is smear positive. But if it is smear negative and they're doing a culture, it may take about two months for the result to come. So that is a problem with that. The other thing was you saw, traditionally we were doing our culture on solid culture on LJ media slopes. But now you have these liquid culture machines available called the MGIT or the Mycobacterial Growth Indicator Tube machine. The 960 indicates that these 3 drawers which you can pull out have microtubules like this, and 960 tubes, 320 in each drawer can go in, and so many samples can be handled at one time. They are very useful because the sensitivity is higher than even the nucleic acid amplification test. These are the culture is the only test which can tell you whether the bacteria are live or dead. So if your patient is on treatment, at the end of treatment, you should not do a nucleic acid amplification test to judge whether the patient is cured or not, because the nucleic acid amplification test can pick up even dead bacilli. So should not be done at that way. There you need a culture. So follow this. These are the tests to do. And certain drugs like bedaquiline, delamine, and pyazonamide, this is the way to pick up the result. So in today's era, you have something called universal DST or UDST, where all your TB patients have a right to know their rifampicin resistance status. So you start with a NAT for all patients, and if you get a rifampicin resistance, these people have a right to know further resistance also, for which you do a first line LPA, which will tell you INH, rifampicin, and ethionomide. A second line probe assay, which will tell you first line, it will tell you second line injectables and fluoroquinolone resistance. And then a liquid culture or MGIT, which will tell you resistance to other drugs like linezolid, profazimin, or bedaquiline, and all. Finally, based on all the resistance results, your regime is tailored for the patient's needs. Well, like 10, 15 years back, I would tell my students that in the USA and all, they do DST guided, drug susceptibility testing guided treatment. We are not able to do it in India. But today in India also, we are doing that, and all our patients are getting the best possible regime as per their requirement. Now, if the NAT is not showing rifampicin resistance detected, then you have to do a first line LPA, which will tell you INH resistance. Now, INH, if there is no INH resistance, then you go with the ordinary DSTB regime. If INH resistance is detected, you have a special regime for INH resistant TB, and that is the regime you give. For extrapulmonary TB, this is more important for us these days because about 34-35% of our cases today are extrapulmonary TB. There was a time when I started my career and RMDCP, only 10 to 15% of cases were supposed to be extrapulmonary. If your district had more than 20% cases extrapulmonary, your district will get a black mark. Then the collector and the health secretary will ask what is going wrong in your district. But today, we are accepting that extrapulmonary TB is higher. At one of the years, Kerala had about 42% of its cases being extrapulmonary. So almost half the cases became extrapulmonary. So you need more facilities for diagnosis of extrapulmonary TB. And if you're suspecting extrapulmonary TB, which suspicion will depend based on the organ and symptoms and all that. So we will not go into details of that. Your first question is tissue available? So if it is a lymph node, you can get tissue. If it is pleural fluid, you can get tissue. If it is skin, you can get tissue. But if, suppose it's a brain lesion and a tuberculoma in the brain, the radiologist is extremely certain that this is a tuberculoma, then you might start ATT without taking tissue. A spine, the spinal surgeon says it's risky to do a surgery in that patient, even though there's a small cold abscess. Why don't we try ATT out? So there you don't take tissue and you might start treatment. Such cases are called clinically diagnosed extrapulmonary TB. But if a tissue is available, which will be available in most cases, you will actually do all these tests, the nucleic acid amplification test, culture if available, and histopathology. Now, if your NAT or culture or smear are positive, you call it microbiologically confirmed extrapulmonary TB. Those diagnosed solely on histopathology, they are called clinically diagnosed extrapulmonary TB. So that is how it goes. And sample quantity and quality is extremely important. Our microbiologists repeatedly keep on telling us, reminding us that you have to send samples properly To the microbiology lab, the sample should not have formalin. So it should go, if at all needed, put a bit of normal saline in it and send in these tubes called the Falcon tube. Our district TB centers and TB workers have these tubes available along with a triple layer packaging, which allows for transportation. The tubes, the transportation, the packaging, everything is free to the patient, and the test is also free to the patient. So you should remember that. The expert supposedly in the initial WHO meta-analysis supposed to show very good results, even though the initial comparison was with culture and composite reference standard. That is, in clinically diagnosed cases, the results were not that good. But still, it was expected that it should be a wonder drug, a wonder test even for extrapulmonary TB. But in practice, many clinicians say that the tests are not performing to their expectation. So if I just show you Trissur data, 2022 data, which we collected, microbiology department did a study on this and collected, you can see that in Trissur Medical, even today, majority of cases are diagnosed based on histopathology. And, the surgeon, orthopedician would say that our results on NAT are poor, which appears so because only 31% of lymph node are actually NAT positive, even though WHO promised 85%. Similarly for other things also. But then the microbiology department looked at it very closely, and then they found that out of the 122 lymph nodes that had presented that year in their database, only 49 actually had undergone a NAT. And in the 49 who underwent the NAT, 78% were NAT positive. Similarly for skeletal TB, out of the 39 who were there, only 10 had undergone a NAT, and out of the 10, 7 were positive, or 70% positivity. So which actually means that the tests are actually performing well. The problem is not with the test. The problem is us clinicians, we are not sending the right test. So, without sending the test, we say that our patients are not getting positive. So we have to be more proactive in sending samples for testing. We should remember that the Union Health Secretary and many other senior bureaucrats who are not doctors, they also know that for extrapulmonary TB, you have to do the test. So review meetings and all at national level, state level, many of them will ask, why didn't you do the test? Why is the microbiological confirmation so low? Problem with histopathology is that you're basing your diagnosis on a granuloma, and granuloma can occur in a large number of conditions. I'll not go into the details of that. And there's the other fact that in Western countries and all, many of the extrapulmonary TB is due to non-tuberculous mycobacteria. But then our country, we really don't know what is the proportion. By doing a NAT, you're also confirming that this is Mycobacterium tuberculosis complex. So you're ruling out NTM also effectively. So there are double advantages and the added advantage of knowing rifampicin resistance also. Remember that the most common form of extrapulmonary TB in our state, this is 2019 data from our state, 36% is lymph node TB, 22% is pleural TB. Both these things, both these conditions cover almost 60% of extrapulmonary TB. It is very easy to get a sample. Even the abdominal TB and all, gastroenterology colleagues would get a sample very easily. From the other forms, which are less common, it might be difficult to get a sample, but at least for the most common forms of extrapulmonary TB disease, we can get samples. I'm running out of time, so I'll skip these scenarios for the time being, and I'll go to the pediatric algorithm. Now, the pediatric diagnostic algorithm is slightly different because challenges in diagnosing TB in pediatrics are different. The suspect criteria are more or less similar. You have fever or cough for more than 2 weeks, fever and or cough for more than 2 weeks. Now, weight loss may not always be there in children. Even a failure to gain weight, not meeting the growth chart, can also be considered as a suspect criteria for TB. And any contact with a known or active, known active TB or a suspected active TB is also considered. Now, what is new in this IAP NTEP algorithm is that Manto test is not there anywhere in this algorithm. Until the previous algorithm, Manto would always figure, but this algorithm has no Manto. It focuses a lot of attention on chest X-ray. And the guideline document, if you read it, I would suggest that you have a look at it. It also tells you what kind of X-ray lesions are highly suggestive of TB, when are non-specific, and when will you consider normal. And in all these suspected TB, you are supposed to somehow get a sample, expectorated sputum, gastric aspirate, or induced sputum, or a bronchoscopy aspirate, and send it for NAT. And then based on the NAT, you're supposed to diagnose. However, they understand that many of these cases, even after evaluation, NAT may be negative or may not be actionable. There, if the clinician feels that this is TB, you can make a diagnosis of clinically diagnosed TB. So it is not necessary that NAT should be positive, but all attempts should be done to do a NAT for the child. Now, these are the X-ray lesions and all. I'm just showing it on the X-ray. Now, the problem in today's scenario, for both for adult patients and pediatric, more so for pediatric patients, we are all losing our skills and confidence to diagnose TB on X-ray. long back, when RNTCP started, our clinicians did not want sputum examination. They all wanted to start. They said, we know how to diagnose TB on X-rays. And it was an ongoing quarrel between pulmonologists and many of us working in the program. But now we come the other way, where people, unless they get an NAT and sputum or culture, something positive, they are very reluctant to start anti-TB drugs. So in that context, the government, WHO and the government of India are now focusing a lot of attention on artificial intelligence and computer-aided diagnosis. This may very soon come into the program. Already it is happening in many parts of India. So the digital X-rays can be read so that, like this particular software called QRA, I would suggest that you can just try it out. For 2 weeks, it is free, and then they'll ask you for payment. So you can just load it on your laptop, and you could just put in an X-ray, load up an X-ray, and see how it works. So this was one of the X-rays I loaded, and the software will tell you where the lesion is, where to look for, and it'll tell you what kind of lesions are there. Here it says cavity, opacity, nodule, and all that. So this is the cavity and all. So it will pick that up for you. It's very sensitive in picking up lesions. So many kind of lesions can be picked up on that. Last part of diagnosis is that we go to TB infection. Now, TB infection, earlier we never used to manage. In today's scenario, we are managing TB infection. The traditional test for TB infection are interferon gamma release assays. The one that we are using in Kerala is the quantiferon TB gold in tube. The traditional test that everybody is familiar with is the tuberculin skin test or the Manto test, which currently is not really possible in India because standardized tuberculin has not been available in our country for a long time. Because standardized tuberculin is not available, there are huge shortages all around the world. Now, when I say standardized tuberculin is not available, you can just send a patient to any private lab and they will come with a tuberculin puttu, which is done with some kind of antigen, which is not standardized. So none of us actually look at, even consider such Manto results. So remember that the tuberculin proper reagent is not available. So to make up for that, a new antigen called CTB, or which is now called CYTB, has been discovered, which is manufactured by Serum Institute of India, and this has been validated. I showed you some of the results of the validation study. And Government of India has already finished price negotiation. DCGA has approved the procurement. So very soon we are expecting that government will actually procure it and distribute it to all of us. So for people who need to be tested for infection, the test in the future might be the CTB. Remember, it's done just like a Manto. So there is no difference between that. It's only that it's a standardized reagent. It's sort of other things. So in diagnosis, I skip this. So we want to treatment. In treatment, why do we treat? Because we want to save lives. 3.5 lakh people die in India. Kerala also, large number of people die. You want to make your patients better. There is a lot of economic gain for the patient, their family, and our economy also. You want to prevent the spread of TB. That is most important for us from a public health point of view, and also prevent the emergence of resistance by giving the right drugs. And you want to do all this with very low side effects because almost every drug that we use can cause severe side effects. The principles of treatment are that you need multiple drugs, you need a longer duration of treatment, and you need a combination of the right drugs given as intensive phase and continuation phase. In this context, remember that one place where Kerala is doing very badly of late is the mortality rate. So if you look at 2023 and 22, our mortality rate was more than 8%. The national average is 4.2%. So we in Kerala, double the number of TB patients are dying as compared to the reported national figure. So we always will find excuses that other states are giving wrong reports. But even if we accept that the other states' reports are wrong, the point that about 8% of our TB patients are dying is not something that we should be happy about. So something better we can do in the way we treat our TB patients. I'll skip these. I'll just come to the treatment proper. So the treatment in the current regime is a daily regime where you give 4 drugs, INH, rifampicin, pyrazinamide, and ethambutol, daily for 8 weeks, that is 2 months, followed by 16 weeks or 4 months of INH, rifampicin, and ethambutol in the continuation phase. This is given as weight-based fixed dose combinations, and each of these tablets has 75 of INH, rifampicin 150, pyrazinamide 400, and ethambutol 275. So these are the weight bands. And based on these weight bands, you give about 2 tablets, 3, 4, 5, or 6. So a healthy person like me, I would be getting 6 tablets if I had to take ETT. But then every now and then you see very, thin patients with a 30 kg weight, 25 kg weight. We have had patients with 20 kg weight, where we have to take the pediatric dosage and give. So they may need only 2 tablets. So based on that, we give the tablets. So these are the tablets, how they look like. The intensive phase tablets are bigger. continuation phase have only INH rifampicin. So each of these tablets has INH rifampicin, pyrazinamide, ethambutol, 75, 150, 400, and 275. So based on the weight, suppose the patient needs 4, he will take 4 on the first day, 4 on the second day, like that for 8 weeks, and then move on to the continuation phase strip where they will take 4, 4, 4 for the next 16 weeks. So that is how they take the tablets. Remember that this is useful because patient cannot take monotherapy. I'll skip this. Remember that for drug-resistant TB, the classification has changed. Now we are using a new set of classification for drugs, which is different for India as compared to what WHO says, which actually looks at group A drugs, which are most effective, which has levoflox, moxiflox, bedaquiline, and linezolid. Bedaquiline is a new drug. Then again, group B, you have clofazimine, cycloserine or terzidone, and then you have delamanid, amikacin, which are the replacement drugs which you use. Why this change occurred is because we have, newer drugs also coming, so this classification may even change. Rituximab has come, Sutazol is coming, so many new drugs are also coming. So these are the new drugs. Some of these drugs were extremely costly, are still extremely costly, not available in the market. So patient gets access to all these drugs if they are treated through our program. It came about because of individual patient data meta-analysis showing that these drugs are extremely effective and have less side effects. I will not spend time on that. So WHO says you need 4 drugs. So you have 3 in group A, you could take 1 from group B and make your intensive phase. But our country decided that linezolid side effects are quite common in our country. So we will use 5 drugs. So you take all 3 from group A and 2 from group B. And then if needed, you go to the replacement drugs and make your regimes. Now the regimes are, there is one regime for INH monopoly resistant regime, TB, which I told you earlier. No rifampicin resistance detected. First line LP is showing INH resistance detected. This is the regime to give, which is a 6 or 9 month regime without intensive or continuation phase, where you give levofloxacin, rifampicin, ethambutol, and pyrazinamide. Remember that this regime can be started at a PSC level itself. You don't have to refer a patient anywhere for this. So your drug sensitive TB regime, the 2 HRZE, 4 HRE regime, and this particular INH monopoly resistant regime can be started by the PSC. The patient doesn't have to go anywhere. Next level MDR regime, there is a short regime and a longer regime. This is started by a committee called the District DRTB Committee, which actually is there at all the district TB centers, or sometimes in medical colleges or bigger hospitals. So those committees can actually start one of these 2 regimes. The preferred regime is the shorter regime. So you have to decide whether to give the short regime or the longer regime. So there are contraindications for the shorter regime. Because shortage of time, I'm not going into that. If there are no contraindications for the shorter regime, then you will give the shorter regime. If there are any of these contraindications, you'll go for the longer regime. This is decided by the district DRTB committee. So you just have to refer those patients who have rifampicin resistance for that. For all forms of TB, drug sensitive, drug resistant, you have to do something called pre-treatment evaluation, which includes, physical examination, height, weight, psychiatric evaluation required, blood sugars, HIV testing, LFT. I'll not go into details of this. Depending on what regime you're giving. For example, if you're giving a bedaquiline containing regime, you need electrolytes and ECG. So for the MDR regimes at the district TB center, they will tell you what are the tests to do, and they might get it done free of cost to patients. For your DSTB, you need only the physical examination, blood sugar, HIV testing, and LFT, which is peculiar for Kerala. Not every states are doing LFT. So ophthal evaluation is also being done for all our patients. It's supposed to be done. Now, the problem with anti-TB drugs is that they're very good drugs. They save patients' lives, but you can have a lot of side effects as well. Major job of the doctors is to ensure that patients do not have severe side effects, that they are picked up early and you make necessary modifications. For example, drug-induced hepatotoxicity, if you pick it up early, when a patient has nausea, vomiting, you should understand all your patients will have vomiting. Most of them will have nausea. So you have to be very, vigilant and pick up those patients who have a hepatotoxicity. Consumer protection cases have been won in scenarios where patient develop hepatotoxicity, not because patient had hepatotoxicity. That occurs because the doctor did not give heed to those symptoms which should have been identified as hepatotoxicity and kept on, ignoring the patient's symptoms. So as long as you pick these things up, it's okay. If the patient has severe nausea, vomiting and all that, do a LFT again. Again, something like depression. Depression, often you see our health workers going and talking to patients. To understand that depression is something that's a pathological condition and the patient needs a psychiatric evaluation, maybe some drugs to be stopped, and maybe antidepressants. You can't just talk to patients and assume that we had multiple suicides in the past where our health workers could not identify depression. Similarly, ocular toxicity, if you pick it up early, it's fully reversible. Whereas if you miss it and patient goes very far into the toxicity, then vision may completely be lost. So we have to be vigilant. Doesn't mean that we should not give drugs. We should give drugs. We should encourage patients, but be careful with that. Newer toxicity have come with the MDR regimes like QT segment prolongation, hypothyroidism, skin discoloration, and all, which were not considered earlier, but nowadays we are all vigilant about these also. Follow-up is very important. The program gives a lot of emphasis on that. Any patient put on treatment should be followed up till the end of treatment, and you have to give specific treatment outcome to all patients. And in fact, the program has a provision for even post-treatment follow-up for 2 years, at 6 months, 12 months to 2 years. But then that is not happening in our state. So that is something that is absolutely necessary, obviously, but it is there in the program guidelines as well, but it is not. The good thing is that, maybe 10 years back, 20 years back, if you diagnosed a XDR-TB or a MDR-TB, MDR-TB is resistance to INH and rifampicin. XDR-TB is if you have added resistance to a fluoroquinolone and another group A drug. Now, if these things were there, it's almost a death sentence for the patient. Most of them used to die. Only about 24-28% used to survive. But today, with the newer drugs, the treatment outcome for MDR, XDR-TB has dramatically improved at national level. More so for Kerala. And if you look at Kerala statistics, you can see that even for INH resistance, for MDR-TB, XDR-TB, the success rates are somewhere around 80%. I mean, if somebody told me this 15 years back, I would have laughed at him. If this person doesn't understand what TB is, what drug resistance is. But today, we are doing extremely well at even unimaginable levels. That is all. The last bit is on treatment of TB infection. This is just, there are 6 regimes recommended by US FDA, CDC, and WHO. I will not go into that. In our country, the regimes available are 6 months of INH and, 3 months of INH rifampicin. It's a new drug. So weekly INH and rifampicin, 12 doses. We also have a second regime, which we use only in Kerala. Now, with the Kerala success, the 3 months of INH rifampicin given daily, which IAP in Kerala took a lead to, choose this regime among the 6 regimes that I showed you earlier. And we used it in Kerala and the regime did extremely well. So now the country is expanding the regime to 6 other states also based on the Kerala success. There are 2 other regimes which are used for, resistant cases where you have 6 months of Leoflox for MDR, XDR and 4 months of rifampicin for INH resistance. Not very frequently used, and anyway, those cases are less in our state. This is not for everybody. TB infection, I told you, is there in 20% of the population. We are not going to diagnose all those 20% and treat them. Very specific groups are only, high-risk groups are being tested and treated. So HIV positive patients, there is no need to test at all, unless if the HIV positive person is a child infant, in which case a contact is needed, but you don't test even that infant. You give 6 months of INH. For children less than 5 years, there is no need to test at all. If their contacts of microbiologically confirmed TB, you will rule out active TB and treat with 3 months of INH and rifampicin daily. For adults and children above 5 years, you need to test before you treat. So such people are tested with the IGRA in Kerala. And if the IGRA is positive, you rule out active TB. And if it is an adolescent or a child, you give 3 months of INH and rifampicin. If it is an adult, you give 3 months of INH rifampicin given weekly, 12 doses. Other high-risk groups, again, you have to test and treat. So you test with IGRA, like if it is a renal transplant patient or a patient with rheumatology patient who is being started on an anti-TNF drug, or a silicosis patient, or such high-risk groups, specific groups are there. There you will test, and if they're positive, you rule out active TB disease, and then you treat with 3 months of INH and rifampicin. You should remember that the new policy has something very new, and the new thing which was very interesting for me is protection of healthcare workers. So this is there, that ensure that all healthcare workers operate in safe environment. So infection control and safety of other patients and safety of all of us doctors and our other staff is also important. Why I say this is that when we started treatment, our first 600 cases in Trivandrum MDR TB center, you can see that about 10% of them were healthcare workers. Most of them were nurses, but some doctors and some other staff were also there, lab technicians and others. So the point I'm trying to make is that while we treat TB, we should also take care of infection control. Kerala had designed a very specific, very nice infection control kit, AIC kit, which later got adopted all over the country. In the hospitals, we also should ensure that people take specific precautions. Our staff also take precautions so that spread of TB inside hospitals and to healthcare workers doesn't. I'll conclude by saying that diagnosis and TB treatment are completely free. In fact, you're giving very costly diagnosis and costly treatment free to your patients. Early diagnosis and prompt, initiation of treatment is essential. There are many new drugs and regimes, and we need to familiarize ourselves with these. With all these newer tests and newer drugs that we have, treatment outcome has become dramatically better now. Infection control is something we should not forget at all. Remember that these days we also manage TB infection in terms of TB preventive therapy. So that also should be made accessible to us. Thank you for the patient listening. We can all work together to end TB in our state, and we are the leaders in the country. So however well we do, the rest of the country learns from us. So you are the leaders, you have to lead the rest of the country. Thank you.
Thank you, Sanjeev sir, for a very elaborative, very crispy, very clear, crispy presentation. And actually, we have got a lot of ideas, and we wish it could be in 2 sessions so that we would be able to recognize more and more details regarding the treatment session also. And sir, what about another area is BPAL, isn't it, with Pritomanid and all these things? Newer regimen is coming. Sir, what is your opinion regarding BPAL and all that?
So there are multiple new regimes for drug-sensitive TB and drug-resistant TB. I did not bring them up because they are not really implemented in India so far. That's what I meant. So there is a regime that is a 4-month regime for drug-sensitive TB. Until recently, we were all saying that the minimum treatment of TB is for 6 months. But now there is a 4-month regime for drug-sensitive TB, which has rifampicin and a quinolone, in that regime. And then you have shorter regimes for drug-resistant TB. And right now, our regime for drug-resistant TB is for, 18 to 20 months for the traditional regime and 9 to 11 months for the shorter regime. So even though you call it shorter, it's still 9 to 11 months. And the BPAL regime, the BPAL-M regime, the TB beat regime, all of them are 6-month regimes. The BPAL and BPAL-M was studied by Union outside of India. The TB beat study was done by our own people at ICMR. So that is also there. Now the program guidelines to start these regimes, because I am in the National Technical Expert Group for treatment, we have already written the guidelines for the BPAL regime and the BPAL-M regime and everything for the government, and it is with the government, it is sitting at the secretary's desk. The problem with those implementing the regime is that you need large number of drugs for, for the BPAL regime, you have bedaquiline is available, linazole is available, Pritomanid is a drug which is not currently available in plenty in India. So those regimes currently are limited. So I'm sitting at the nodal center. If there is a patient who cannot be fitted into any other regime, as a salvage for such a patient, I can give BPAL regime. I send a specific request to Central TB Division and they'll provide me with the drug. So I can do it under experimental conditions. But if I want to roll it out, we are talking of like more than 1 lakh patients who will need all these drugs, which in the current scenario, it's not available in the costly, so the government cannot hold that.
I heard it is very promising, sir. That's why I asked.
Yeah, 6 months is promising, but there are other issues also in terms of patient should not have received bedaquiline in the past. You have to look for bedaquiline resistance, and so many other things are there. So newer diagnostic technology, everything would be needed. You can't just roll out the regime. You also need to increase your infrastructure. I think there are some questions. If you can,
of course. The platform is now open for questions. Members can ask questions to Sanjeev sir.
I think I can pick up one question. Dr. Ali is asking on concluding treatment for spinal TB. So spinal TB, the recommended treatment is for 1 year. Now, all forms of extrapulmonary TB, not just spinal TB, all forms of extrapulmonary TB, determining an endpoint for treatment is very difficult. So, lymph node TB also at the end of 6 months, about 20% of people will have persistent nodes. If you do ultrasound, as in the current guidelines actually recommend for ultrasound, and if the ultrasound shows nodes more than 1 centimeter, you're supposed to evaluate those nodes further. Now, in spinal TB also, the spinal surgeons and the orthopedicians would do MRI at the end of it. If there is a cold abscess, we'll go ahead and, aspirate and maybe send again for a culture and all that. But your question is very valid, and there is no, correct answer in terms of, when and how you can stop. So it's on individualized collective decision between multidisciplinary teams. And somebody asked on the standardization of CTB in children. Yeah, I mean, we did the validation study initially in adults, and then we also did a ICMR. We were also partners with ICMR. We did a validation study in children also. Kerala, the 4 districts I showed you earlier, Kollam, Trissur, and Kannur also took part in that validation study for CTB for children, and it was found to be extremely good. It was based on this validation on adults and children that Government of India actually, the DCGI gave approval for CTB, and Government of India is procuring CTB. So the validation, standardization, all that is all over. Now we have to actually go ahead with the procurement, price negotiation, procurement. Generally with the Government of India, that takes 1 to 2 years. So I'm not sure when it will come, but the process already started.
Sir, another question came is whether is it necessary, mandatory to give pyridoxine to all patients on ATT? And the question asked by Dr. from Changanur.
Okay, so we have a GO which came in which suggested that you give pyrazinamide to all patients. So the current status, I mean, if Babu or Shinobi or somebody, whether it is actually being done, maybe they can jump in and answer. So the order is there. In between, there was issue of procurement of pyridoxine, issues of shortage and all that. Local procurement was needed in every district. Some districts had shortage. So I'm not really sure on how the practice is happening at ground level, but it was suggested in between that all patients may be given this. There was an order which came from Delhi. Shinobi or Babu are in London. You can just add on to that, whether it's actually happening in all the districts.
I think Babu sir was there.
Yeah, Babu, Shinobi was there. Shinobi also was there.
Pyridoxine diabetic patients, lactating and pregnant, pyridoxine 50 milligram daily. 100 milligram tablets available. പിന്നുള്ളവർക്ക് അല്ലാത്തവർക്കൊക്കെ നമ്മൾ 100 milligram once weekly കൊടുക്കുന്നുണ്ട്. ഡ്രഗ്സ് അവൈലബിൾ ആണ്. പക്ഷെ ഓൺലി തിങ് ഈസ് 100 milligram pyridoxine ആണ് അവൈലബിൾ ഉള്ളൂ. അപ്പോൾ നമ്മളിപ്പോൾ ചെയ്യുന്നത് ഡയബറ്റീസ്, ലാക്ടേറ്റിംഗ് ആൻഡ് അങ്ങനെയുള്ളവർക്കൊക്കെ, പ്രഗ്നന്റൊക്കെ 50 milligram ഡെയിലി കൊടുക്കും, ഹാഫ് ടാബ് ഡെയിലി കൊടുക്കും. അല്ലാത്തവർക്ക് 100 milligram once weekly കൊടുക്കും pyridoxine.
So what Dr. Babu is at PTC Kottayam, so he says it is now being given to all patients. In terms of how much to give, so tablet strength and all that is the limitation.
Sir, another out of the context question. Many patients are complaining of features suggestive of peripheral neuropathy, like features after taking anti-TB drugs. Can you give pregabalin for that?
Okay, peripheral neuropathy can occur with INH. It's not that common. On the minimum, I mean, you try out one by one, you try out various things, including tricyclic antidepressants, various vitamins, and like you suggested, people do try what you suggested also, but whether that actually works or not, I don't know. Now, linezolid in MDR TB, when you have peripheral neuropathy, that is very severe and maybe irreversible. So we try reducing the dose of linezolid, and if that doesn't work, we stop the linezolid even. So INH is a very crucial drug. INH nammal chadi keru nirthi kazhinjal, then treatment outcome of the patient will be affected. So nammal adu enganengilum theerkkan patto, vera endengalum marunnu support cheyan patto nokkum. Even that becomes very severe, you may even consider stopping the drug. But then always go with a group opinion. We have difficult treat clinics at every district, and we can actually take decisions. Symptomatic hyperuricemia, you have to treat. You can give NSAIDs. There is no consensus now on giving any allopurinol or anything like that, which maybe many people used to do earlier. So again, if that is very severe, then we may even consider stopping pyrazinamide. So changing to insulin is not mandatory. Even though, in between in Kerala, we did try to change all our patients to insulin when they have diabetes. It's a very valid question, because about 30% of 35% of our patients in Kerala have diabetes, as opposed to less than 10% at national average. So we are the diabetes headquarters in terms of total diabetes, and TB patients obviously have more diabetes. MDR have even more diabetes. So treating diabetes, trying to control diabetes is essential, but it is not necessary, absolutely necessary that you have to give insulin.
Any other questions?
Food support, yeah, food support is very important. Somebody has asked on that. So, in fact, the government of India has invested 600 crore rupees on food for TB patients. It is called the Nikshay Poshan Yojana. So, the divided with so many patients in India, so that is throughout the treatment. MDR treatment, they will get that 500 rupees per month for the entire period. Then there's the state level support of 1,000 rupees, which is all for nutrition. Over and above that, now there is a study called the ration study, which was done in many states in India by ICMR, which shows that if you give support, nutritional support to the entire family, occurrence of TB in the other family members can dramatically be reduced. So, now there is an increased focus on nutrition, just not for the patient alone, but also for the family. So that is coming up.
ബാലസാറിന്റെ ഒരു ക്വസ്റ്റ്യൻ ഉണ്ടായിരുന്നു, ഡ്രഗ് റെസിസ്റ്റന്റ് ടിബിയുടെ കോണ്ടാക്ട്സിന്റെ പ്രിവെന്റീവ് തെറാപ്പി.
ഓക്കെ, ഡ്രഗ് റെസിസ്റ്റന്റ് ടിബി അദ്ദേഹം നമ്മളെ കൂടെ ഉള്ള കമ്മിറ്റിയിലുള്ള ആളാണ്. നമ്മള് എല്ലാരും കൂടെ ചേർന്ന് തീരുമാനം എടുത്തതായിരുന്നു കൊടുക്കാന്നുള്ളത്. I mean, last time also it took, there was a bit of concern among our own colleagues at the district TB centers, ശരിയാവോ ഇല്ലേ എന്നുള്ളത്. So there is enough and more evidence that INH resistance ഉണ്ടെങ്കിൽ you can give 4 months of rifampicin. അതിൽ എവിഡൻസിന് ഒരു ലാക്കും ഇല്ല. That can easily be given. Majority of our resistance is INH resistance. INH resistant patient കൊടുക്കാം. റിഫാംബിസിൻ അല്ലെങ്കിൽ MDR റെസിസ്റ്റൻസ് ഉള്ള പേഷ്യൻസ് 6 മാസം ലിവോഫ്ലോക്സ് കൊടുക്കണം എന്നായിരുന്നു പീഡിയാട്രീഷ്യൻസിന്റെയും ഞങ്ങളുടെയും എക്സ്പേർട്സിന്റെ എല്ലാവരും അഭിപ്രായം. അത് ഇംപ്ലിമെന്റ് ചെയ്ത് തുടങ്ങി എന്നാണ് ഞാൻ മനസ്സിലാക്കിയത്. ബാബു, അത് ആയോ? കോട്ടയത്തൊക്കെ ആയോ?
സഞ്ജീവ് സർ,
പ്രശ്നമുണ്ട്.
ഡോക്ടർ ബാലേന്ദ്ര
പറഞ്ഞു
സാർ, അത് ഞാൻ ചോദിച്ചത് അത് ജിയോ ആയോ എന്നുള്ളതാണ് ഞാൻ ചോദിച്ചത്.
ബാബുവിന്റെ അടുത്ത് അതാ ചോദിച്ചത്. ബാബു അതാ പറഞ്ഞോട്ടെ.
സാർ, ഞങ്ങൾക്ക് മെസ്സേജ് വന്നു, മെയിൽ വന്നു, ഒഫീഷ്യൽ മെയിൽ വന്നു. പക്ഷെ അവിടെ പ്രോബ്ലം ഡ്രഗ് ഷോർട്ടേജ് ആണ്. നമുക്ക് ലോക്കൽ പർച്ചേസേ ഉള്ളൂ. അപ്പൊ തൽക്കാലം ഡ്രഗ് സ്റ്റേറ്റ് സെൻട്രൽ TB ഡിവിഷൻ വരാതെ നമ്മൾ തൽക്കാലം സ്റ്റാർട്ട് ചെയ്യുന്നില്ല. സ്റ്റാർട്ട് ചെയ്തോളാൻ പറഞ്ഞിട്ടുള്ള മെസ്സേജ് വന്നിട്ടുണ്ട്.
പറഞ്ഞ പോലെ what we decided has now been conveyed by the state TB officer, has got the minutes ready. He has given the order to district. So I think from our side what we could do and the state level what could be done is done. Now it's an issue of working out the logistics. മരുന്ന് കൊടുത്തു തുടങ്ങിയ എല്ലാവർക്കും കൊടുക്കണ്ടേ? അപ്പൊ അത്രയും അതിനുള്ള മരുന്നും അതെല്ലാം അവൈലബിൾ ആക്കിയിട്ട് വേണം അത് തുടങ്ങിയിട്ട് പകുതിക്ക് വെച്ച് മരുന്നില്ലാതെ കഴിഞ്ഞാൽ that is dangerous.
അതുപോലെ സാർ, ഇഗ്ര is it freely available throughout the state?
ഇഗ്രയ്ക്കും I mean I've been last 4 days I have had multiple programs, particularly to the private medical colleges like പോകുമ്പോൾ അവിടെ എല്ലാം constant complaint that I'm hearing from my fellow faculty in the private medical colleges and all that. അവർ ഇഗ്ര വിടുമ്പം പിന്നെ 1 മാസം കഴിഞ്ഞ് 2 മാസം കഴിഞ്ഞൊക്കെ ചെയ്യുള്ളൂ എന്ന് പറയുന്നു. സോ പ്രൈവറ്റ് ആകുമ്പോൾ പേഷ്യൻസ് ആർ മോർ ഡിമാൻഡിങ്. 1 മാസം 2 മാസം ഒക്കെ ടെസ്റ്റിന് വെയിറ്റ് ചെയ്യാൻ they're not even willing. So I think that is also an issue which needs to be taken up. The IGRA issue, I think it has been a long-standing issue, and I am hopefully very soon we will get the CYTB. So once we get that, then our IGRA problem temporarily solved. So the new antigen comes in, then availability of, if that is available in plenty, പിന്നെ പേഷ്യന്റിനെ ഇഗ്രയ്ക്ക് വിടുക, ഇഗ്രയ്ക്ക് അങ്ങോട്ടും ഇങ്ങോട്ടും സാമ്പിൾ കളക്ട് ചെയ്യുക, അതിന്റെ ഒന്നും ആവശ്യം വരില്ല. യു ക്യാൻ ടെസ്റ്റ് വിത്ത് ദ CYT. That would be the more appropriate.
Suppose IGRA is not available, patient is affording, can we do with 2 units of Mando?
ഇല്ല, മാൻഡോ എന്ന് പറഞ്ഞാൽ സാർ 2 യൂണിറ്റ്സ് കുത്തുമ്പോൾ അതിന്റെ പേഷ്യന്റ് സ്റ്റാൻഡർഡൈസ് അല്ലല്ലോ. വാട്ട് യു അസ്യൂം ആസ് 2 യൂണിറ്റ് കുത്തുമ്പോൾ ചിലർക്ക് 10 ആയിരിക്കും പോകണം, ചിലർക്ക് 50 ആയിരിക്കും പോകണം, ചിലർക്ക് 1 ആയിരിക്കും പോകണം. അതാണ് അതിന്റെ പ്രശ്നം, സ്റ്റാൻഡർഡൈസ് അല്ല. അപ്പൊ അത്
എല്ലാവരും
അർത്ഥം
including in medical college, they are using Mando with 2 units.
As far as possible, ഞങ്ങൾ ഇപ്പം ഇന്നലെ I was with IAP in Trissur, അനന്തേഷൻ സാറ് മീറ്റിംഗ് നടത്തിയിരുന്നു. And they all sort of agreed that now they are agreeing that they will not use non-standardized Mando. അപ്പൊ അങ്ങനെ ഒരു I think you have to take the leadership. IAP has to take the leadership and move. Anyway, CTB ഉടനെ വരും. അത് വരുമ്പം then you don't have to use any non-standardized things.
In kids also.
Kids also. It's validated, and you should definitely for kids only.
അത് ഇഗ്ര സെയിം ഇഗ്ര ആന്റിജൻ അല്ലേ സാർ ഉപയോഗിക്കുന്ന?
ഇഗ്രയിൽ ഉപയോഗിക്കുന്ന 2 ആന്റിജൻസ് ആണ് CYTBയിൽ ഉപയോഗിക്കുന്നത്. ആൻഡ് ഇൻ വെരി വാലിഡേറ്റഡ് ഡെഫിനിറ്റ് ഡോസേജിലാണ് അത് വരുന്നത്. സ്റ്റാൻഡർഡൈസ്ഡ് ആകുമ്പോൾ ഈ നോൺ സ്റ്റാൻഡർഡൈസ്ഡ് ട്യൂബർക്കുലിൻ ആകുമ്പോൾ അതിന്റെ അകത്ത് കോക്ടെയിൽ ഓഫ് ട്യൂബർക്കുലിൻ എന്ന് പറഞ്ഞാൽ കോക്ടെയിൽ ഓഫ് ആന്റിജൻസ് അല്ലേ, കുറെ 100 ആന്റിജൻസ് ഉണ്ട്. അതൊക്കെ ഏതൊക്കെ എത്ര ലെവലിൽ വരും എന്നുള്ള സ്റ്റാൻഡർഡൈസ്ഡ് അല്ലെങ്കിൽ പലർക്കും പല രീതിയിലായിരിക്കും കിട്ടണം. You cannot compare results between patients. So the non-standardized tuberculin should not be used എന്ന് കഴിഞ്ഞ ഒരു 10-15 വർഷമായിട്ട് IAP ജേർണലിൽ എല്ലാ വർഷവും വരുന്ന സാധനം. IAP themselves have agreed should not be used. പക്ഷെ ആള് ട്രഡീഷണലി യൂസ് ചെയ്ത് ശീലമായി കഴിഞ്ഞപ്പം അതില്ലാതെ പറ്റുന്നു. ഒരു കാലത്ത് മറ്റേ IgG IgM അങ്ങനെയായിരുന്നു, പലരും അത് യൂസ് ചെയ്തുകൊണ്ടിരുന്നു. സർക്കാർ ഒരു ദിവസം പിന്നെ പെട്ടെന്ന് അങ്ങ് ബാൻ ചെയ്തു, ഇനി ആരും അത് ഉപയോഗിക്കാൻ പാടില്ല. പ്രിസ്ക്രൈബിങ് IgG IgM, doing IgG IgM in a lab or even purchasing the kit in a lab is illegal, punishable offense. അതോടെ അത് നിന്നുപോയി. ആ സമയത്ത് എല്ലാ ക്ലിനീഷ്യൻസും വന്ന് ഞങ്ങളുടെ അടുത്തൊക്കെ ചൂടായി, ഇത് നിർത്തി കഴിഞ്ഞാൽ ഞങ്ങൾ എന്ത് ചെയ്യും. You should remember that until it was banned, 60% of the money of TB patients in India spent on diagnosis was being spent on IgG and IgM, which was one fine day suddenly banned by the government. So much of money was saved by TB patients, but totally useless drugs they were wasting. That would be used on more useful things.
ഇഗ്ര റീപ്ലേസ്മെന്റ് ആയിട്ട് അല്ല സാർ പലപ്പോഴും യൂസ് ചെയ്യുന്നത്, ഇപ്പോഴും ഡയഗ്നോസ്റ്റിക് അൽഗോരിതത്തിനകത്താണ് പലപ്പോഴും യൂസ് ചെയ്യുന്നത്.
അത് വേറെ ഇഷ്യൂ. ഡയഗ്നോസ്റ്റിക് അൽഗോരിതത്തിൽ IAP has already taken it out, so there is no role at all. I am considered as a TB expert at national level. ഞാൻ കഴിഞ്ഞ 20-30 വർഷമായിട്ട് TB ട്രീറ്റ് ചെയ്യാൻ, ഞാൻ ഇതുവരെ ഒരു TB ഡയഗ്നോസ് ചെയ്യാൻ പാൻറ്റോ ഇഗ്ര യൂസ് ചെയ്തിട്ടില്ല. I must have treated thousands or maybe lakhs of TB patients all over. So at least adult pulmonologists, we don't have to use a IGRA or a PANTO. It's mainly for pediatrics. I can understand the logic. Even adult pulmonologists, extra pulmonary treat ചെയ്യുന്ന I can understand why they are doing it. But any international guideline, you read either country guideline എടുത്താലും, it very clearly says that IGRA or MANTO cannot rule out TB disease. അപ്പോൾ നെഗറ്റീവ് ആണെങ്കിൽ ഡിസീസ് ഇല്ലാന്നും പലരും കൺക്ലൂഡ് ചെയ്യും, അതും പറ്റില്ല. And a positive test cannot conclude that there is disease, because if you do a IGRA for Korean women are അവിടെ ഇരിക്കും, സാറിന്റെ മാൻറ്റോ ഒക്കെ ചെയ്ത് കഴിഞ്ഞാൽ ഹൈലി പോസിറ്റീവ് ആയിരിക്കും, IGRA ചെയ്താലും പോസിറ്റീവ് ആയിരിക്കും. സോ ഇഫ് ഹി ഹാസ് എ ഫീവർ ഓഫ് 3 weeks ഡ്യൂറേഷൻ, ഇപ്പോഴത്തെ പനിയൊക്കെ പലതും മാറാത്ത പനികളുണ്ട്, ഏതെങ്കിലും ഒരു ചുമ വന്ന് 3 ആഴ്ച മാറാതിരുന്ന പുള്ളിയുടെ ഒരു മാൻറ്റോ ചെയ്താൽ അത് എന്തായാലും പോസിറ്റീവ് ആയിരിക്കും, അദ്ദേഹത്തിന് നമ്മൾ പേര് ട്രീറ്റ് ചെയ്യാൻ പോണില്ല. അപ്പൊ ആ രീതിയിൽ ആ ടെസ്റ്റുകൾക്ക് പ്രസക്തി. കുര്യൻ സാർ എന്തെങ്കിലും പറയണം സീനിയോറിറ്റി ഇത് വെച്ച്?
Sanjeev, ഒന്നും പറയാൻ കൂടുതലായിട്ടൊന്നും പറയാനില്ല, but it is very happy to see you all, because you said about the MDR TB. We are not now we are treating in a good way, good way. We are treating for MDR TB, and by my concern, even though our incidence in the Kerala is 115 per million population, our death rate is very high. I think 88%.
സാറിന് ഓർമ്മയുണ്ടാവും, സാറ് DT ആയിരുന്നപ്പോൾ ഞാൻ DT ആയിരുന്ന കാലത്തൊക്കെ 4% മുകളിൽ ഡെത്ത് പോയി കഴിഞ്ഞാൽ നമ്മള് ഡൽഹിയിൽ ചീത്ത വിളിച്ചു കൊണ്ടുപോയത്.
ഡൽഹിയിൽ
പോയി നമ്മൾ അവിടുത്തെ ഹെൽത്ത് സെക്രട്ടറി ചീത്ത കേട്ടിട്ട് വന്നിട്ടുണ്ട്. ഡോക്ടർ സെബാസ്റ്റ്യൻ മലപ്പുറം DTO സ്ഥിരം ഡൽഹിയിൽ ചീത്ത കേൾക്കാൻ പോകുമായിരുന്നു.
4% കൂടി it was very humiliating to us. And also for extrapulmonary tuberculosis in Pathanamthitta, it was more than 30%. It was equally പ്രയാസമായി പോയത്. അതുപോലെ പത്തനംതിട്ടയിൽ HIV കൂടുതലായതുകൊണ്ടായിരിക്കാം എക്സ്ട്രാപൾമണറി കൂട്ടുന്നത്. നമ്മൾ അതുപോലെ ഡൽഹി വെച്ച് തന്നെ ഹരാസ് ചെയ്തതാണ് അവര്. Now it is, I think it is more than 40% it is extrapulmonary tuberculosis.
പക്ഷെ മോർട്ടാലിറ്റി കൂടുതലാണെന്ന് എല്ലാരും പറയുന്നുണ്ട്. നമ്മൾ അതിന് എന്തെങ്കിലും ആക്ഷൻ എടുക്കണം. വി ഷുഡ് അണ്ടർസ്റ്റാൻഡ് ദാറ്റ് തൊട്ടടുത്ത സ്റ്റേറ്റ് തമിഴ്നാട്ടില് മോർട്ടാലിറ്റി ഇത്രയും ഇല്ല, അവർക്ക് 5% മോർട്ടാലിറ്റി ഉള്ളൂ. പക്ഷെ അതുപോലും കൂടുതലാണെന്ന് പറഞ്ഞ് തമിഴ്നാട് ഗവൺമെന്റ് ഒരു പ്രത്യേക സ്കീം കൊണ്ടുവന്ന് മോർട്ടാലിറ്റി കുറയ്ക്കാനായിട്ട് കുറെ നീക്കങ്ങളുണ്ട്. ഇറ്റ്സ് ബിക്കം എ നാഷണൽ മോഡൽ. ഇപ്പം ഇതുവരെയുള്ള കാലത്തൊക്കെ കുര്യൻ സാറൊക്കെ പറഞ്ഞ നമ്മളിപ്പം പേഷ്യന്റ് വൈസ് ഡ്രഗ്സ് വരുന്നില്ല, പേഷ്യന്റ് വൈസ് കിറ്റ്സിന്റെ ഹിസ്റ്ററി നിങ്ങൾക്ക് അറിയില്ലെങ്കിൽ ഡോക്ടർ കുര്യൻ ഉമ്മനാണ് അത് DTC പത്തനംതിട്ടയിൽ ഇരുന്ന് പ്ലാസ്റ്റിക് കവറിനകത്ത് ചെറിയ ഒരു പേഷ്യന്റിന് ആവശ്യമുള്ള ഡ്രഗ് ഇങ്ങനെ സ്റ്റേപ്പിൾ ചെയ്ത് കിറ്റ് ആദ്യമായിട്ട് ഉണ്ടാക്കി. അത് കണ്ടിട്ടാണ് നാഷണൽ ലെവലിൽ ഇങ്ങനെ പേഷ്യന്റ് വൈസ് കിറ്റ് ഉണ്ടാക്കാൻ പറ്റുന്നത്. ഡോട്ട്സ് എത്ര സക്സസ്ഫുൾ ആണെന്നും ഡോട്ട്സ് വേഴ്സസ് നോൺ ഡോട്ട്സ് ഏറ്റവും നല്ലൊരു സ്റ്റഡി, ഏറ്റവും കൂടുതൽ സൈറ്റേഷൻ ഉള്ള സ്റ്റഡി അഗൈൻ പത്തനംതിട്ടയിൽ ഡോക്ടർ കുര്യൻ ഉമ്മന്റെ സ്റ്റഡിയാണ്. അത് നോൺ അക്കാഡമിക് ഒരു ഡിസ്ട്രിക്ട് TB സെന്ററിൽ ഇരിക്കുന്ന ആളുടെ സ്റ്റഡി ഇന്നും ഒരു 250 സൈറ്റേഷൻ ഉണ്ട്. വിച്ച് ആ ഒരു അക്കാഡമിക്സിൽ വർക്ക് ചെയ്യണ ഞങ്ങൾക്കാണ് 250 സൈറ്റേഷന്റെ ഒക്കെ ഇമ്പോർട്ടൻസ് അറിയാവുന്നത്. എനിക്ക് ഒരു സ്റ്റഡിക്ക് എന്റെ 1-2 സ്റ്റഡിക്കും ഉണ്ട്, ഞാൻ ചെയ്ത സ്റ്റഡികൾക്ക്. അല്ലാതെ മൾട്ടി സ്റ്റേഷൻ സ്റ്റഡിക്കും ഈ പറഞ്ഞ 250 മുകളിൽ സൈറ്റേഷൻ ഉണ്ട്. പക്ഷെ അങ്ങനെ ഒരു സ്റ്റഡിയിൽ 250 സൈറ്റേഷൻ കിട്ടുക എക്സ്ട്രീം പ്രൈഡ് ഓഫ് മാറ്റർ ഓഫ് എക്സ്ട്രീം പ്രൈഡ്. ആൻഡ് ദാറ്റ് കെയിം ഇൻ 2000-ല് 10-25 വർഷം മുമ്പ് പത്തനംതിട്ട പോലെ കുറച്ചുകൂടെ റിമോട്ട് ആയിട്ടുള്ള ഒരു കോളേജ് പോലും അന്നില്ലാത്ത ഒരു ഡിസ്ട്രിക്ട് ചെയ്യുന്ന ഒരു ഡോക്ടറിന്റെ സ്റ്റഡി ആണെന്ന് പറഞ്ഞാൽ ഇറ്റ്സ് എ മാറ്റർ ഓഫ് പ്രൈഡ് ഫോർ ഓൾ ഓഫ് us മലയാളീസ് ഫോർ എ ലോങ് ടൈം. അന്ന് എനിക്കൊന്നും സ്റ്റഡി പോലും ഇല്ലായിരുന്നു. അങ്ങനെ ഒരു കാലത്ത് ചെയ്തിട്ടുണ്ട്. റിച്ച് ഹിസ്റ്ററി ഇൻ കേരള വിത്ത് ഓൾ ദീസ് നമ്മളത് മറന്നുപോരും. ഞാനിപ്പം എനിക്ക് കുര്യൻ സാർ എനിക്കും പ്രായമായി തുടങ്ങിയ ലക്ഷണമായിരിക്കും. ഞാൻ ഓൾവേസ് കീപ് റിപ്പീറ്റിംഗ് ദാറ്റ് വി ഷുഡ് നോട്ട് ഫർഗെറ്റ് അവർ ഹിസ്റ്ററി. ഈ ഇന്നുള്ള പല പ്രോബ്ലംസിന്റെയും സൊല്യൂഷൻ നമ്മളെ ഹിസ്റ്ററി ഓഫ് TB ഇൻ കേരള നോക്കിക്കഴിഞ്ഞാൽ വി ഹാവ് solutions which are available in the past. Health Service Department in Kerala has brought out excellent solutions. So, can be done. നമ്മള് ഇവിടെയും ഇപ്പോഴുള്ള ജനറേഷനും ഇപ്പൊ ഷിനോബി ബാബു ഒക്കെ എക്സ്ട്രീംലി ഗുഡ് ഇൻ മെനി സൊല്യൂഷൻസ് ആയിരിക്കും. ഇപ്പം സൈഡ് എഫക്ട്സിന്റെ കാര്യം പറയുമ്പോൾ ഷിനോബി അവിടെ ഉണ്ട്, മീറ്റിംഗിലുണ്ട്. അപ്പം 1 fine day ഷിനോബി ഇങ്ങനെ ഞങ്ങളെ സ്റ്റേറ്റ് ലെവൽ എക്സ്പേർട്ട് കമ്മിറ്റിക്ക് ഒരു കേസ് പ്രസന്റ് ചെയ്യുക എന്ന് വെച്ചാൽ ഒരു പേഷ്യന്റ്, കോട്ടയത്തുള്ള പേഷ്യന്റ്, മരുന്ന് കഴിക്കുമ്പം അടുത്ത മൊമെന്റ് തൊട്ട് പേഷ്യന്റെ വിഷൻ എല്ലാം നീല നിറവും. ഞങ്ങൾ എല്ലാവരും എക്സ്പേർട്സ് ഉണ്ട്. ഞങ്ങൾ പറഞ്ഞു ഷിനോബി അങ്ങനെയൊന്നും വരില്ല, അത് അൺലൈക്ലി, അത് പേഷ്യന്റ് തോന്നണായിരിക്കും. ഷിനോബി തന്നെ ബൈ എക്സ്പെരിമെന്റ് ഓരോരോ ഡ്രഗ് ടെസ്റ്റ് ചെയ്ത് നോക്കിയിട്ട് എത്തിയോണമൈഡ് നിർത്തി കഴിഞ്ഞാൽ പേഷ്യന്റ് ആ പ്രശ്നം ഇല്ലാന്ന് മനസ്സിലാക്കുകയും എത്തിയോണമൈഡ് കാരണമാണ് അത് വരുന്നത്. അനിത മാഡം ഞങ്ങളെ HOD ഇങ്ങനെ ഇത് ഷിനോബി അത് ശരിയാണോ എന്നൊക്കെ ഇങ്ങനെ ഡിസ്കസ് ചെയ്തുകൊണ്ടിരിക്കുമ്പോൾ നമ്മൾ ഓൺലൈൻ മീറ്റിംഗ് ആണല്ലോ, അപ്പൊ അതിനിടയ്ക്ക് ഞാൻ സെർച്ച് ചെയ്ത് നോക്കിയപ്പോൾ NTIT called Synoptia, which until then none of the experts knew about it. So ഡോക്ടർ ഷിനോബിയാണ് അത് കൊണ്ടുവന്നത്. ഇന്നിപ്പോ ഞാൻ നാഷണൽ ലെവൽ ടോക്കിനൊക്കെ പോകുമ്പോൾ എല്ലായിടത്തും ഡോക്ടർ ഷിനോബി ഇങ്ങനെ ഒരു സൈനോപ്തിയ കണ്ടുപിടിച്ചു എന്ന് പറയും. അതുപോലെ ഐ ക്യാൻ സി ഡോക്ടർ ബിന്ദു ജോസഫ് ദയർ നല്ലൊരു കേസ് ഓഫ് നൊക്കാർഡിയോസിസ് കണ്ടുപിടിച്ചു, TB എല്ലാം കണ്ടു. വി ഹാവ് ഓൾ അവർ ടീം ഹിയർ ആർ എക്സ്ട്രീംലി ഗുഡ്. അപ്പൊ ഇങ്ങനെ ഇത്രയും നല്ലൊരു ടീം ഉണ്ടായിട്ട് കേരളത്തിൽ എന്തുകൊണ്ട് 8% മോർട്ടാലിറ്റി എന്ന് പറഞ്ഞാൽ അത് കുറച്ചൊരു ഡിഫിക്കൽട്ട് ടു ബിലീവ്. പിന്നെ ഈ പറഞ്ഞ 3 മാസം 6 മാസമുള്ള പേഷ്യൻസ് ഒക്കെ ഡയഗ്നോസ് ആവാതെ കേരളത്തിൽ നടക്കണമെന്ന് പറയുന്നതും നമുക്കൊരു മാറ്റർ ഓഫ് അത് കാരണമാണ് ഡെത്ത് ഉണ്ടാവും. സോ ഡോക്ടർ ബിന്ദു പറയുന്നതാണ് അവിടുത്തെ പോയിന്റ് എന്ന് വെച്ചാൽ ഈ കോവിഡിന് മുമ്പുള്ള കാലഘട്ടത്തിൽ നമ്മൾ വേറെ ഇന്ത്യയിൽ ബാക്കിയുള്ള സ്ഥലത്തേക്ക് എക്സാമിനറൊക്കെ ആയിട്ട് പോകുമ്പോൾ ഈ ബയലാറ്ററൽ എക്സ്റ്റെൻസീവ് ഡിസീസ് ക്യാവിറ്റിയൊക്കെ ആയിട്ടുള്ള പേഷ്യന്റ് നമുക്ക് കൊതി വരും. എന്ന് വെച്ചാൽ ബ്രോങ്കിൽ ബ്രീത്തിങ് ഒന്നും ഇന്ന് കേൾക്കാൻ കിട്ടാറുണ്ടായിരുന്നില്ല. അപ്പൊ പിള്ളേരെ പഠിപ്പിക്കാൻ ബ്രോങ്കിൽ ബ്രീത്തിങ് വേണ്ട, അത് കിട്ടൂല. അപ്പൊ അതൊന്നും ഇല്ലാതെ ഇങ്ങനെ നടന്നതാണ്. പെട്ടെന്ന് കോവിഡ് വന്നു കഴിഞ്ഞ് ഇപ്പം നോക്കുമ്പോൾ പേഷ്യൻസ് എല്ലാം ഞാൻ നിങ്ങൾക്ക് കാണിച്ചെന്ന 3 എക്സ്റേ കണ്ടല്ലോ, വലിയ ക്യാവിറ്റീസ് ആണ്, നല്ല ബ്രോങ്കിൽ ബ്രീത്തിങ് ഉള്ള പേഷ്യൻസ്. ഇതൊന്നും കേരളത്തിൽ ഇല്ലായിരുന്നു, അതെല്ലാം തിരിച്ചു വരുന്നു. അപ്പൊ അതിന്റെ ബിന്ദു അതാണ് പറഞ്ഞത്, അങ്ങനെയുള്ള പേഷ്യൻസ് വരുന്നു. അപ്പൊ ഓബ്വിയസ്ലി TB എക്സ്റ്റൻസീവ് ആയിട്ട് വരുമ്പോൾ മരണവും കൂടുതലുണ്ടാവും. അപ്പൊ അതിന്റെ സൊല്യൂഷൻ പേഷ്യൻസിനെ നേരത്തെ ഡയഗ്നോസ് ചെയ്യുക. അപ്പൊ നമ്മളെ സിസ്റ്റം കുറച്ചുകൂടെ സ്ട്രെങ്തൻ ചെയ്യുക എന്നുള്ളത്. ഇത്രയും നല്ല സിസ്റ്റം ഉണ്ട്. ആരോ ഇന്ന് കഴിഞ്ഞ ദിവസം കമ്മ്യൂണിറ്റി മെഡിസിൻ HOD വന്ന് ചോദിച്ചു, ഈ പറഞ്ഞ എന്തുകൊണ്ടാ കേരളത്തിൽ ഇത്രയും നല്ല ഹെൽത്ത് സീക്കിംഗ് ബിഹേവിയർ ഉള്ള ഒരു സ്ഥലത്ത് പേഷ്യൻസ് ഇത്രയും ഡിലേ ആണ്. എനിക്ക് തോന്നിയ ഒരു സൊല്യൂഷൻ പ്രോബ്ലം ഞങ്ങൾ ആലോചിച്ചപ്പം ഇന്ന് ഈ വൈറൽ കോവിഡ് ഉൾപ്പെടെയുള്ള എല്ലാ വൈറൽ ഡിസീസും നമ്മൾ ചുമ ഇങ്ങനെ മാറാതെ എല്ലാവർക്കും ഉണ്ട് അല്ലെ. നമുക്കും പലർക്കും ചുമ വന്നിട്ട് 3-4 മാസം മാറാതെ നിൽക്കുന്നുണ്ട്. ഡോക്ടർമാർ നോക്കുമ്പോൾ അങ്ങനെ കുറെ പേഷ്യൻസ് വരുന്നുണ്ട്. അപ്പം മേ ബി കോഫ് ഹാസ് ബിക്കം സിംറ്റം ഓഫ് വേരിയസ് അതർ ഡിസീസസ്. ഇതിനിടയ്ക്ക് people are not thinking of TB. I don't know what the problem is. Anyway, there is a problem and we need to find solutions.
I think that's chronic cough. I think we are using extensively steroids ഇപ്പം യൂസ് ചെയ്യുന്നുണ്ട്. Any chronic cough not responding to the treatment, everybody is using steroids. In the case of tuberculosis കേസിലെ I think this may be one of the reason. പക്ഷെ ഇങ്ങനെയുള്ള എക്സ്റേ കാണുന്ന സങ്കടം തോന്നുന്നുണ്ട് കേട്ടോ. ഞാനൊന്ന് വിചാരിക്കുക, നിങ്ങൾ സജി കാണിച്ച 3 എക്സ്റേ എക്സ്റ്റൻസീവ് ലീഷൻ നമ്മൾ കേരളത്തിൽ എനിക്ക് ഇതുപോലെ ലീഷൻസ് കാണാൻ പാടില്ലാത്തതാണ്.
എല്ലാരും കഫ് വന്ന് ബ്യൂട്ടിക്കൗട്ട് അടിച്ച് നടക്കുക. ബ്യൂട്ടിക്കൗട്ട് റാമ്പന്റ് ആയിട്ട് കൊടുക്കുന്നുണ്ട്. പറയാൻ പറ്റില്ല.
ഈ TB ഇൻഫെക്ഷൻ ലേറ്റന്റ് TB എന്നുള്ള ടെർമിനോളജി ഇപ്പൊ നമ്മൾ ഒഫീഷ്യലി ഏതാണ് സ്റ്റിക്ക് ഓൺ ചെയ്യുന്നത്? അത് ഈ പറഞ്ഞ പോലെ നമ്മള്
ഞാൻ TB ഇൻഫെക്ഷൻ ഞാൻ അതിന്റെ ചെയറായി വന്ന സമയത്ത് ഞാൻ TB ഇൻഫെക്ഷൻ എന്ന് പറഞ്ഞാണ് തുടങ്ങിയത്. അപ്പൊ എന്റെ കൂട്ടുകാർ ഷിബു എല്ലാ WHO കൺസൾട്ടന്റ് എന്നെ അടിച്ചേൽപ്പിച്ച് എന്നെ കൊണ്ട് ലേറ്റന്റ് TB ഇൻഫെക്ഷൻ എന്നെ കൊണ്ട് പഠിപ്പിച്ചു കഴിഞ്ഞാൽ പിന്നെയും തിരിച്ചെല്ലാരും TB ഇൻഫെക്ഷൻ എന്ന് പറഞ്ഞു തുടങ്ങി. ഇപ്പൊ അറിയാതെ TB ഇൻഫെക്ഷൻ ആണോ ലേറ്റന്റ് TB ഡെഫിനിഷൻ വായിച്ചാൽ ഇപ്പോഴും ലേറ്റന്റ് TB ഇൻഫെക്ഷൻ എന്നാണ് ആ ഡെഫിനിഷനിൽ കിടക്കുന്നത്. TB ഇൻഫെക്ഷൻ എന്നുള്ള ടെർമിനോളജിയാണ് വേറെ പല ഡോക്യുമെന്റ്സിൽ യൂസ് ചെയ്യുന്നത്. ഒരു ഫേം ആയിട്ട് ഒരു ടെർമിനോളജിയിൽ എത്തണം എന്നാണ് എനിക്ക്. From that latent TB, there was a moving towards TB infection. Now, How it will actually end up, I'm not very sure. I would assume that currently the better terminology will be TB infection, because ആ latent എന്ന് പറയുമ്പോൾ അതിന്റെ ഇംഗ്ലീഷിന്റെ ഇതാണ്. നമ്മൾ ഈ പറഞ്ഞ TB സസ്പെക്റ്റഡ് TB ഉള്ള ആളുകളുടെ പേര് ഇങ്ങനെ മാറ്റിക്കൊണ്ടിരിക്കും. ഇനീഷ്യലി they were called TB suspect. അപ്പൊ ഈ TB suspect എന്ന് പറയുന്ന ഒരാളെ ഇൻസൾട്ട് ചെയ്യണം, ഇംഗ്ലീഷിന്റെ പ്രത്യേകത. അപ്പൊ ഇംഗ്ലീഷുകാർ നോക്കുമ്പോൾ TB suspect എന്ന് പറഞ്ഞാൽ അവരെ നാണം കെടുത്തതാണ്, ആ ടെർമിനോളജി മാറ്റണം എന്ന് പറഞ്ഞാൽ പ്രിസംറ്റീവ് പൾമണറി TB ഇപ്പൊ ആക്കിയത്. അതുപോലെ ഈ ലേറ്റന്റ് എന്നുള്ളത് യൂസ് ചെയ്യുമ്പോൾ അതിനൊരു അർത്ഥം റോങ് മെസ്സേജ് കൺവേ ചെയ്യണം എന്ന് പറഞ്ഞാൽ ലേറ്റന്റ് ഡ്രോപ്പ് ചെയ്യാൻ അവസരം.
ഒഫീഷ്യലി WHO എങ്ങനെയാണ് ഇപ്പൊ ലേറ്റസ്റ്റ് ലേറ്റന്റ്
TB ഇൻഫെക്ഷൻ എന്നായിരുന്നു അവസാനമൊക്കെ ഞാൻ വായിച്ചത്. ഒന്നുകൂടെ ഒന്ന് നോക്കണം.
താങ്ക് യു.
സർ, 2 ക്വസ്റ്റ്യൻ കൂടെ വന്നിട്ടുണ്ട്. ഹൗ കോമൺ ഈസ് നോൺ ട്യൂബർക്കുലസ് മൈക്രോബാക്ടീരിയൽ ഇൻഫെക്ഷൻ? ഡസ് പാരഗോണിമസ് വെസ്റ്റർമാനി കോസ് ദിസ് എന്നുള്ള ഒരു ക്വസ്റ്റ്യൻ. 2, ഇൻഹേൽഡ് സ്റ്റിറോയിഡ്സ് മാസ്ക് ആൻഡ് ഡിലേ ഡയഗ്നോസിസ് ഓഫ് TB എസ്പെഷ്യലി ഇൻ പീഡിയാട്രിക്സ് ഓർ അഡൽട്സ്.
ഓക്കെ, ദ ഫസ്റ്റ് വൺ NTM, ഹൗ കോമൺ ഇറ്റ് ഇസ് നമുക്ക് ശരിക്കും പറഞ്ഞാൽ അറിയില്ല. നമ്മൾ നേരത്തെ സ്പ്യൂട്ടം ചെയ്തുകൊണ്ടിരുന്നപ്പം സ്പ്യൂട്ടം പോസിറ്റീവും നാറ്റ് നെഗറ്റീവ് ആയിരുന്നെങ്കിൽ we would think that this is NTM. Now the problem is that we stopped doing sputum in many places. അപ്പോൾ നേരെ നാറ്റാ ചെയ്യുന്നത്. നാറ്റ് പോസിറ്റീവ് ആയി കഴിഞ്ഞാൽ it is already NTM is ruled out. So one of the issues of going to upfront NAT is that we will not pick up NTM. We should know that many countries in the world today, pulmonary TB due to NTM is more common than pulmonary TB due to Mycobacterium tuberculosis. In US and all, extrapulmonary TB already NTM was present in 90% of cases in children. So in even pulmonary TB, many countries in the world, NTM has overtaken. But that same thing might happen to us. ഞങ്ങൾ അവസാനം ഒരിക്കൽ കണക്കെടുത്തപ്പം ബിഫോർ വി സ്റ്റോപ്ഡ് ഡൂയിങ് സ്പ്യൂട്ടം ഇൻ ഓൾ പേഷ്യൻസ് ആൻഡ് ഓൾ, ആ സമയത്ത് around 5% of our patients were sputum positive and NAT negative. അതിലെല്ലാം ഒന്നും NTM ആയിരിക്കില്ല, ബട്ട് അറ്റ് വിൽ ബി അറൌണ്ട് 2-3% ആയിരിക്കും ഉണ്ടാവണം ഉള്ള പേഷ്യൻസ്. അതിന് മുമ്പുള്ള കാലഘട്ടത്തിൽ 99-2000 ആ സമയത്തൊക്കെ എല്ലാവരും കൾച്ചർ ചെയ്ത് NIRT-കാരൊക്കെ പറഞ്ഞാൽ ഇറ്റ്സ് ഓൾ 99% MTB ആണെന്ന് ഇന്ത്യയിൽ. മേ ബി ഇറ്റ് ഇസ് മോർ നൗ അബൌട്ട് 2-3-4% വിൽ ബി NTM. ഈ നോൺ റെസ്പോണ്ടേഴ്സിൽ നമ്മൾ കാണുന്ന ഇപ്പം ഡോക്ടർ ഷിനോബിയോ ബാബുവോ ഞാനൊക്കെ കാണുന്ന ആ ലെവലിൽ മരുന്ന് എടുത്തിട്ടും മാറാത്ത കേസസ് വരുമ്പോൾ അതിന് NTMന്റെ പ്രൊപ്പോർഷൻ കൂടും. ബിക്കോസ് ബൈ ദെൻ മോർ ഈ പാരഗോണിമസ് വെസ്റ്റമനി ആയിട്ട് അതിന് വേറെ അസോസിയേഷൻ ഒന്നുമില്ല, അത് വേറെ ടോട്ടലി ഡിഫറെന്റ് ആണ്. അതിനുള്ള വേറൊരു സ്റ്റഡി ഡോക്ടർ മനു ഹെൽത്ത് സർവീസ് ഡിപ്പാർട്ട്മെന്റിന്റെ സ്റ്റേറ്റ് TB സെല്ലിൽ ചെയ്തിരുന്നു. പാരസിറ്റിക് ഇൻഫെക്ഷൻസ് വേറെയാണ്. ഇൻഹേൽ സ്റ്റിറോയിഡ്സ് are a risk factor for TB. So, if you read the COPD guidelines, they say that for a person at risk of TB, old TB or TB, as far as possible, don't use inhaled corticosteroid. Thailand, there are studies which show that, inhaled steroids, COPD, there is a higher incidence of tuberculosis, which means that inhaled steroids have a strong association with TB. On the other hand, asthma, that doesn't apply. Asthma, steroid. COPD, പിന്നെ സാറ് പറഞ്ഞ പോലെ എല്ലാ ചുമയ്ക്കും സ്റ്റീറോയിഡ് കൊടുക്കും. ദാറ്റ് ഓൾസോ ഹാസ് ഇമ്പാക്ട് ഇൻ ദാറ്റ് പർട്ടിക്കുലർ വേ. ബിന്ദു അത് തന്നെ പറഞ്ഞു. മാസ്ക് വോൺ ബൈ എ പേഷ്യന്റ്, നോട്ട് ബൈ അസ്. നമ്മൾ N95 ബാക്കിയുള്ള ഇൻഫെക്ഷൻ കൺട്രോളിന് വേറെ മെഷേഴ്സ് ഉണ്ട്. ഇഫ് എ പേഷ്യന്റ് വെയർസ് എ സർജിക്കൽ മാസ്ക്, ദാറ്റ് ഇസ് പ്രൊട്ടക്റ്റീവ്. സോ generally we should encourage our patients to wear mask. It will be protective. But the problem is, the greatest spread of TB occurs to close contacts. വീടുകളിലും അങ്ങനെയുള്ള സാഹചര്യം. അവിടെ ഒന്നും ആരും മാസ്ക് കിട്ടാറില്ല. വെളിയിൽ ഇറങ്ങി മാസ്ക് കിട്ടിയാലും വീട്ടിൽ പോകുമ്പോൾ ഊരി വയ്ക്കും. സോ വീട്ടിൽ കെട്ടാനാണ് നമ്മൾ ആ ഇൻഫെക്ഷൻ കൺട്രോൾ കിറ്റിൽ മാസ്ക് കൊടുത്തത്. ബട്ട് ഐ ഡോണ്ട് നോ വാട്ട് പ്രൊപ്പോർഷൻ ഓഫ് പേഷ്യൻസ് ആക്ച്വലി യൂസ് ഇറ്റ്. കുട്ടികൾ മാസ്ക് കിട്ടുമ്പോൾ കുട്ടികൾ ദർ പോസിബിൾ ആയിട്ടുള്ളത്. അപ്പോൾ ദർ ലെസ് ലൈക്ലി ടു സ്പ്രെഡ്. സീറോ അല്ല, ബട്ട് ദർ ലെസ് ലൈക്ലി ടു സ്പ്രെഡ്. സോ മെയിൻലി അഡൽട്സ് ഹു സ്പ്രെഡ് TB. സോ അഡൽട്സ് ഷുഡ് ബി ടേക്കിംഗ് കെയർ ഓഫ് ഇൻഫെക്ഷൻ കൺട്രോൾ മോർ ദാൻ ചിൽഡ്രൻ.
സാർ, ഒരു ഡൗട്ട് ഇവിടെ. കാരണം ഇപ്പൊ കറണ്ട് മറ്റേ ഗൈഡ് ലൈൻസിൽ പീഡിയാട്രിക്സ് ഗ്രൂപ്പിൽ സ്കിൻ ടെസ്റ്റ് ഉപയോഗിക്കുന്നില്ലേ സാർ? ഇപ്പൊ അതിന്റെ കാര്യം സ്കിൻ ടെസ്റ്റ്
പുതിയ ഗൈഡ് ലൈനിൽ ഒരിടത്തും സ്കിൻ ടെസ്റ്റ് ഇല്ല. ആ ഗൈഡ് ലൈൻ IAP ഉണ്ടാക്കിയത്. അപ്പൊ ഒരു IAP ഞാൻ എപ്പോഴും കൺഗ്രാജുലേറ്റ് ചെയ്യണം. എന്താന്ന് പറഞ്ഞു കഴിഞ്ഞാൽ IAP ഈസ് ദ ഓൺലി അസോസിയേഷൻ which has sat down with Government of India and they make guidelines together. ഞങ്ങളെ അസോസിയേഷൻ, ഇന്ത്യൻ ചെസ് സൊസൈറ്റി അല്ലെങ്കിൽ നാഷണൽ കോളേജ് ചെസ് ഫിസിഷ്യൻസ് ഇന്ന് വരെ പ്രോഗ്രാമായിട്ട് കൺസെൻസസ് എത്തിയിട്ടില്ല. ഞങ്ങളുടെ രീതി, അവരുടെ രീതി എന്നാണ്. ഞങ്ങൾ പിന്നെ ഇൻഡിവിജ്വൽസ് ആണ്. കുര്യൻ സാറോ ഞാനോ ഷിനോബിയോ ബാബോ അങ്ങനെയുള്ളവര്, ബിന്ദു അങ്ങനെയുള്ളവരൊക്കെ പ്രോഗ്രാമിന്റെ കൂടെ നിൽക്കണമെന്നല്ലാതെ എല്ലാ പൾമണോളജിസ്റ്റ് ഒന്നും വേറെ ഇന്ത്യയിൽ പല സ്റ്റേറ്റിലും പോയി കഴിഞ്ഞാൽ they don't follow, UP-ലൊന്നും they don't follow guidelines of the program. So IAP still follows program guidelines, which is a very good thing on part of IAP. But those guidelines are actually made with IAP and program together. ഞങ്ങളൊക്കെ ഗൈഡ് ലൈൻ എഴുതാൻ പോകുമ്പോൾ ആ ഒരു ഭാഗം തൊടാനേ സമ്മതിക്കും. ദിസ് ഇസ് മെയ്ഡ് വിത്ത് IAP, നിങ്ങൾ ഇതിനെ മോഡിഫൈ ചെയ്യാൻ നിങ്ങൾക്ക് അധികാരമില്ല. അപ്പൊ അങ്ങനെയുള്ള സാധനം ആയതുകൊണ്ട് IAP സാധനം ആയതുകൊണ്ട് I think all pediatricians should accept.
I am very happy that Dr. Bindu Joseph is also my classmate, just like Dr. Preeta as well. Thank you so much, sir, for a very extensive, very crispy, very clear presentation. And I invite Dr. Praveen to say a word of thanks.
വേൾഡ് TB ഡേ മാർച്ച് 24 തന്നെ സാറിനെ കിട്ടിയത് നമ്മുടെ ഒരു വളരെ വലിയ ഭാഗ്യമായിട്ട് കാണുന്നു. കാരണം TBയെ പറ്റി വളരെ എക്സ്റ്റെൻസീവ് ആയിട്ട് ഇനി ഒരു ഡൗട്ട് ഉണ്ടാവാൻ സാധ്യതയില്ലാത്ത രീതിയിൽ ഇൻക്ലൂഡിങ് പീഡിയാട്രിക് TB വളരെ നല്ല രീതിയിൽ സാറ് പ്രസന്റ് ചെയ്തു. സാറും ഞാനും ഈ പറഞ്ഞ പോലെ പല TOTകളിലും നമ്മുടെ ഇൻക്ലൂഡിങ് പീഡിയാട്രിക് ലേറ്റന്റ് TB നമ്മൾ റോൾ ഔട്ട് ചെയ്ത സമയത്തും സാറ് തന്നെ ആയിരുന്നു നമുക്കെല്ലാം അതിന്റെ ക്ലാസ് എടുത്തത്. അപ്പോൾ അതുകൊണ്ട് തന്നെ സാറ് നമ്മുടെ ഈ ഒരു TBയുടെ കാര്യത്തിൽ തന്നെ ഒരു സ്റ്റേറ്റിലെ തന്നെ ഒരു അല്ലെങ്കിൽ നാഷണൽ ലെവലിലെ തന്നെ ഒരു എക്സ്പേർട്ട് ആണ്. അപ്പം സാറിന് നമ്മുടെ എല്ലാവരുടെയും പേരിൽ KGMOAയുടെ മൊത്തം ഫാമിലിയുടെ പേരിലുള്ള നന്ദി സാറിനെ അറിയിക്കുകയാണ്. അതുപോലെ തന്നെ ഈ പ്രോഗ്രാം ഓർഗനൈസ് ചെയ്ത കോട്ടയം KGMOA, അതേപോലെ തന്നെ സ്റ്റേറ്റ് അക്കാഡമിക് സെല്ലിന്റെ ചെയർപേഴ്സൺ വിൻസെന്റ് സാറ്, സ്റ്റേറ്റ് പ്രസിഡന്റ് സുരേഷ് സാറ്, എല്ലാവർക്കും ഒറ്റ വാക്കിൽ നന്ദി പറയുന്നു. പിന്നെ നല്ല പാർട്ടിസിപ്പേഷൻ ഉണ്ടായിരുന്നു. ഏകദേശം 200 പേരോളം പാർട്ടിസിപ്പേറ്റ് ചെയ്തു. അവസാനം വരെ എല്ലാവരും പാർട്ടിസിപ്പേറ്റ് ചെയ്തു. അപ്പൊ എല്ലാവർക്കും നന്ദി പറഞ്ഞുകൊണ്ട് നിർത്തുന്നു. താങ്ക് യു.
Thank you once again, sir, each and every one of you. Thank you, Sanjeev, sir.
Thank you
sir.
for the invitation, and also congratulations to KGMOA for having taken this up. എനിക്ക് തോന്നുന്നു ആദ്യമായിട്ടാണെന്ന് തോന്നുന്നു KGMOA ഈ നല്ലൊരു ലെവലിൽ വേൾഡ് TB ഡേ ഇത്രയും നന്നായിട്ട് ഓർഗനൈസ് ചെയ്തു. So congratulations to you.
Thank you, sir. Thank you.
Thank you.
Thank you.
താങ്ക് യു.